Chapter 8, Human Patient Simulator Simulation. Introduction. When considering the incorporation of human simulator simulations in the education of healthcare professionals, it is important to understand the principles, practice, and methodologies necessary for a successful simulation experience. Included in this understanding is knowledge of the relationship between the learner and the environment and how healthcare decisions will be assessed and evaluated. When using human simulators as an educational tool, the designer of the simulation scenario incorporates learning methodologies into the process of planning, implementation, and evaluation of the learning that takes place with human simulator simulation experiences. There are many outcomes that can be measured using simulation. Among them are technical and non-technical skills, as well as the ability to assess human behavior. Simulation principles. Simulation-based learning, SBL, provides a real-life scenario in an accurate setting where participants respond as they would in an actual event. Many healthcare institutions and academic settings are using SBL to educate and evaluate healthcare professionals and those in educational programs to become future healthcare professionals. SBL includes 3 stages. In the first stage, the participant receives information from the facilitator about the scenario, discovers the objectives of the simulation, what their role will be, and other necessary information. In the second stage, the participant actively engages in the simulation. In the third stage, debriefing, participants share their experience, emotions, and actions. In addition to task and technical skills, SBL can also be used to identify problem-solving and decision-making skills. Sarfati et al. Found that SBL can help prevent medication errors if the key elements of scenario design, debriefing, and assessment of perception are clearly identified. Team education, communication, and interpersonal skills are evaluated during SBL. To use simulation effectively, sound teaching, learning principles are needed. Without sound principles and planning, adverse consequences can easily occur during a simulation experience. Some common problems identified during simulation scenarios involving teams include a group that does not understand that each team member has a unique role, lack of clear role definition resulting in role confusion, no plan in place to use when mistakes or errors occur, no method to measure individual or team performance. The success of using simulator scenarios to educate healthcare professionals should be measured in relationship to the improvement in clinical competence and the potential or actual impact on patient safety and outcomes. It is important to evaluate team performance during simulations, not just individual demonstration of knowledge, skills, and attitudes. Deliberate practice. Using human simulator experiences gives the learner an opportunity to practice and acquire clinical skills without causing patient harm. A core principle of human simulator education is the concept of deliberate practice, DP. DP is defined as a learner's endeavor to practice for the purpose of improving a task or skill beyond the current level of proficiency. Using the concept of DP, simulation can improve the effectiveness of the learning experience. An integral component of DP is critical reflection. A student must recognize a deficit in knowledge in an effort to seek learning opportunities to narrow this gap in knowledge. With the assistance of a healthcare simulation educator, the learner becomes actively engaged in practicing and improving a task, skill, or decision-making process. When a learner engages in DP, feedback from the healthcare simulation educator is necessary to communicate improvement in learner skill acquisition and retention. Team training. Similar to a real clinical environment, human simulator scenarios often include a small group of participants rather than just an individual learner. Understanding the role of each member of the healthcare team and knowing when to delegate are the goals of building teams. Knowing how to incorporate the principles of team education and crisis resource management, CRM, into a scenario involving more than one learner builds this competency. The first step in team education in simulation is to articulate the specific competencies targeted toward acquiring team building skills. Once these competencies are recognized, a level of measurement can be calculated to guide the debriefing process. Using simulation to educate healthcare teams can help replicate conditions where a mix of professionals can practice and learn from each other. Interprofessional simulation can facilitate interaction among members to develop teamworking and communication skills. By practicing together, each participant will have a better understanding of each other's roles and responsibilities. Learners can use this opportunity to develop a professional identity and participate in shared decision-making. Badowski and Oosterhuis completed a quasi-experimental pretest/post-test design where a simulation-based, peer-coached, deliberate practice clinical substitution was implemented to compare nursing students' knowledge, skills, and attitudes in promoting safety. The results demonstrated improved knowledge and skill acquisition in the intervention and control groups. There was a trend toward improved team communication attitudes and skill performance. Team learning principles can be applied with a team of students from the same discipline or an interprofessional group using human simulator education. The Agency for Healthcare Research and Quality, AHRQ, developed a framework for building teams, team strategies and tools to enhance performance and patient safety. This process of team training is designed for healthcare professionals to improve patient safety and achieve better patient outcomes. Simulation aids in the acquisition of team skills by allowing the learner to practice in a simulated, safe environment. Using team steps in simulation is one way to aid in the design, measurement of objectives, and evaluation of team training. Table 8.1. Table 8.1 Components of team training in human simulator simulations. Members delegate tasks to other team members, plan, organize, and motivate. Leadership other team members. Members have a shared understanding of group dynamics and team roles and peer observation are able to recognize errors and openly communicate ideas and suggestions for correction. Members are able to adapt or change as the scenario unfolds or the group. Flexibility dynamics change. Group members recognize that the work of the team is paramount and individual membership goals are secondary. The workload of all team members should be balanced and match the balanced knowledge and skills of each individual. Trust. An atmosphere of mutual trust should exist in which individuals are able to share knowledge and speak about errors in judgment and action and accept constructive feedback. Communication. All members of the team are able to openly communicate, confirm that their message was heard and understood, and clarify the message if necessary. Simulation teaching tip 8.1 If at all possible, when assigning learners to teams, make every team diverse. Diversity in race, gender, as well as role should be considered for every interprofessional team in order to teach cultural awareness and sensitivity as well as group collaboration. Within Team Steps training is a principle known as CUS, which stands for, I am concerned, I am uncomfortable, this is a safety issue. The purpose of CUS is to empower individuals to speak up if they are concerned about an actual or potential breach in safety. Included in the CUS course of action is a 2-challenge rule. Under this rule, if individuals feel that their concern has not been recognized, they should verbalize this concern at least twice. If, after the second exchange, the team member concludes that the response is not acceptable, the team member is expected to take a different, more assertive course. This alternate course may include following the chain of command to ensure a safe environment. The CUS rule can be employed during a simulation scenario and measured as part of the evaluation criteria. Crisis resource management. Another method of assessing teams is through the process of CRM. When CRM began in the aviation industry, it was originally called crew resource management. The principles of CRM have been incorporated into the training of healthcare professionals. Healthcare teams can be large, composed of members with diverse skill sets, responsibilities, and actions. The key principles of CRM are: have a clear leader and well-defined roles. Value input from all resources and personnel. Have a plan and share and adapt the plan as needed. Request help early. Distribute the work and support all members of the team. Prioritize and delegate tasks to others. Give everyone the right to be assertive and to speak up. Have timely, specific, and constructive communication. Using the principles of CRM within a simulation scenario will help the team perform in a coordinated and efficient manner during the care of a simulated patient. Closed-loop communication. When communicating to members of the team during simulations, it is imperative that each individual's message is heard and understood. Closed-loop communication is a method of communication in which there is a sender and a receiver of a specific message. Exhibit 8.1. Employing a closed-loop communication aids the coordination of care, confirming to the sender that the message was received. Exhibit 8.1 Closed-loop communication. A sender delivers a message to a receiver. The receiver of the message acknowledges that the message was received and ascribes meaning to the message. The sender communicates with the receiver to ensure that the expected meaning was conferred through the message. If the sender does not feel that the message was interpreted as intended, the conversation continues until the loop is closed. SPAR communication. The acronym SPAR stands for Introduction, Situation, Background, Assessment, and Recommendation. SPAR communication is an organized, structured method of two-way communication in a healthcare setting. The person conferring the information provides the following: S. A short, but relevant summary of the current situation. B. The patient's background relevant to the information exchange. A. Important assessment findings. Are A recommendation for action on the part of the receiver of the information. Healthcare providers must effectively and accurately communicate patient information. Using SPAR to communicate during simulation scenarios can improve the clarity of communication and give the learner an opportunity to practice this important skill. Simulation methodology. Experiential learning. A methodology is the theoretical analysis of the body of methods and principles associated with a body of knowledge. Kolb's model of experiential learning is often applied to simulation learning. Kolb's model places the learner into one of four steps: concrete experience, reflective observation, abstract conceptualization, and active experimentation. Concrete experience. The learner will experience the situation by doing. Reflective observation. The learner will review the experience on a personal basis by thinking about what they did. Abstract conceptualization. The learner will form abstract concepts that can be used in future experiences. Active experimentation. The learner can apply what was learned in the previous steps. Experiential learning requires the learner to develop competence over time through the practice of experiential learning. Inherent within the concept of experiential learning is how experience contributes to the process of learning. For learning to occur, it is imperative that there is active participation, with reflection on the decisions made. In simulations, experiences are artificially constructed with the purpose of eliciting defined outcomes. Learning takes place through the simulation experience, during the debriefing process, and when participants conceptualize events and become involved in decision-making. Because the learners are living the experience during simulation, they are able to increase their engagement. Due to the reality of the setting, the learners are more engaged and interact more fully in the activity. The goal of experiential learning is to gain new knowledge and understanding of key concepts or principles. During experiential learning, learners are asked to perform within a defined role in an activity that has context and meaning for them. Adult learning simulation is a technique that uses guided experience to replicate the real world in a manner that is thoroughly interactive. Adult learners practice the concepts of andragogy, teaching of adults, in the simulation environment. Knowles developed the concept of andragogy. Adult learners are self-directed and independent and consider that they are responsible for their own learning. Adult learners also have experience and previously learned knowledge that can be used as a resource for future learning. Ensuring a proper environment for learning is another principle of adult learning. This is also the basis of using simulation to educate healthcare professionals. Because simulation allows adults to practice skills and behaviors in a team environment, it has the ability to motivate adults to learn. Adult learners expect their performance is confidential after a simulation is concluded. This is especially challenging when both the simulation and the debriefing are group experiences. The simulation educator, while providing a safe, rich learning environment, must maintain respect and support for the adult learner during simulation and maintain the confidentiality of all involved. In addition, the participants of the simulation must also respect the need to maintain confidentiality of the actions during the simulation scenario and debriefing to protect the privacy of all participants. There are additional concepts related to adult learners not originally considered by Knowles. Not all adults learn in the same way. Learning is situation-specific and there are many factors that affect the adult learner. One important factor in adult learning is how a person's culture affects learning and professional growth. It is also assumed that adults experience information overload and are not capable of additional learning. In addition to teaching tasks, simulation andragogy can also be used to develop interpersonal relationships such as empathy, which is linked to caring, compassion, kindness, and responsiveness. The challenge for educators using simulation is to convey the importance and value of the experience for the adult learner. Situational awareness. Situational awareness is comprised of three parts: gathering information from the environment, synthesizing, interpreting, and prioritizing the current system, and predicting and planning for future events. This shared cognizance helps each team member to see the larger picture during a simulation scenario rather than concentrating only on an individual task. When situational awareness is employed during a scenario, all team members are kept informed and updated on the plan of care and all new developments in patient status. Ensuring that the learner is oriented to the simulation environment will contribute to a successful encounter. Rapid cycle deliberate practice. A novel approach to simulation learning is a methodology termed rapid cycle deliberate practice. This process allows the learner to complete a simulation, receive immediate feedback, and continue to practice until mastery is achieved. Rapid cycle DP can also be used in simulation to practice increasingly more challenging skills, with the facilitator giving immediate feedback with short debriefing and a pause and rewind technique within the scenario. Low to high fidelity simulation. The concept of simulation is not new in medical education. However, the use of high fidelity simulators in healthcare provider education has been a relatively new phenomenon. Fidelity is the measure to which the simulator or the simulation matches the real environment the scenario is attempting to simulate. Fidelity in simulation can include an array of approaches, from role play to complex mannequins with advanced physiology. Task trainers and low, medium, and high-fidelity mannequins all have an established place in medical education. Due to significant advancements in simulator technology, it is now possible to create a simulated environment using many simulation strategies to construct a setting very close to the real world. Today's high-fidelity mannequins are capable of a multitude of physiologic functions. In addition to mannequin fidelity, there is also physical, functional, psychological, and task fidelity, which adds to the realism for the learner. High-fidelity simulations can be more resource-intensive and costly. Current high-fidelity mannequins are available in models representing different stages of the lifespan, from fetal and neonatal through adult. High-fidelity mannequins can be used for specific tasks, such as central line placement, while whole-body mannequins can be used to respond with complex, multi-system, physiologic adaptation to the learner's actions or inactions. Advancement in the science of designing high-fidelity human simulators continues as technology improves. What is available today may seem primitive in only a few years as advancements in computerization, robotics, and materials science improve our ability to create a more realistic human simulator. Evidence-Based Simulation Practice 8.2. Landy et al. Conducted a qualitative study exploring caregivers' perceptions of simulation-based education, SBE, in the care of a child with tracheostomy. The study found that caregivers preferred high physical fidelity in SBE and believed it influenced engagement during the experience. Functional fidelity. Functional fidelity is the degree of accuracy in the operation of the simulated system. When operating a computerized, high-fidelity mannequin, the physiologic manifestations should be as close as possible to how a real person would respond. Responses to medication administration, oxygen delivery, and other treatments should be manifested in the mannequin as in a real human. An important consideration is the training of the simulator operator. Adequate training is imperative to be able to present a mannequin with high function fidelity to the learner. Participants initially perceive the mannequin as a technically based non-human. As the simulation progresses, the reality of the scenario improves and the responses become more meaningful as the participants interact with other people and objects within the environment. Learners who are socially engaged during the simulation are more likely to perceive what is being represented as real. Task fidelity. Task fidelity is the measure of how authentic the simulated task is compared with a real task. It is important to match the task with the knowledge of the learner. During simulation, learners should not be expected to perform a task for which they have not been educated or that is outside of their scope of practice. Using complex high-fidelity simulators to educate a novice in basic skills is not necessary when a less complex simulator may be more appropriate. When using a simulator to learn a skill, task fidelity should be very close to what the learner will experience within a real setting to avoid transfer of negative motor skills and to promote transfer of positive motor skills. Physical fidelity. Physical fidelity refers to the environment where the simulation takes place. This includes the visual, auditory, kinesthetic or tactile, and spatial surroundings. When able, the setting should resemble real clinical structures as closely as possible. Equipment and furnishings within the setting should be fully functioning. Attention to detail is an important part of physical fidelity. Some simulation centers take every aspect of the physical environment into consideration when preparing for a simulation scenario. Changing the room temperature, changing time on the clocks, and adding authentic odors are some examples of increasing the physical fidelity of a simulation scenario. Psychological fidelity. Psychological fidelity is the degree to which the educational situation evokes the same psychological conditions that would be present in a real clinical setting. This aspect of simulation fidelity is not always easy to secure. Simulations ask the learner to forget temporarily that the scenario is not real and engage in the activity, believing in its authenticity. It can take great effort to plan the physical, functional, and task fidelity, but it is up to the learner to consider the psychological fidelity of the scenario. Chapter 9, Moldage in Simulation. Introduction. Moldage is a French term that means casting or molding. Today, it is the art of applying mock injuries for the purpose of training healthcare personnel. The formal practice dates back to the 18th century, when wax figures and castings of body parts were used for this purpose. The concept of using models in education can also be seen in early Greek culture. Thus, the use of simulated injuries and illnesses, or MOLIDGE, to educate healthcare practitioners is not new. However, its utilization in modern education is expanding. This chapter provides an overview of MOLIDGE and its use in casualty and illness simulation. The chapter discusses makeup as well as an indication of the educational basis for its choice as a tool to use in simulation. Several broad areas are addressed, covering ideas involving the use of MOLIDGE in specific situations, with human patient simulators, HPS, or mannequins, and with standardized patients, SPs, setting the stage by adding props and standardized participants, confederates, and some of the specific techniques as well as the process of cleanup. The more advanced concepts of making your own MOLIDGE supplies and materials are also addressed. The chapter includes educational basis for MOLIDGE, basic MOLIDGE supplies, actors and makeup, MOLIDGE for SPs, mannequins and makeup, MOLIDGE for HPS, special effects basics, creating props and setting the stage, striking the set, cleaning up and resetting the scenario. The use of MOLIDGE in a simulation scenario is limited only by the scenario developer's imagination and expertise. Care must be taken, however, to keep this imagination from running wild, as excessive or inappropriate MOLIDGE or makeup can detract from the simulation or provide incorrect cues. Educational basis for the use of MOLIDGE in simulation. Although there has been a paucity of actual research on the use of MOLIDGE and makeup in educational simulation, this is beginning to change. Anecdotal reports are still plentiful and relate various degrees of success and failure. Some current studies are evaluating the degree of realism and its impact on the learner and are focusing the research agenda. The use of MOLIDGE in simulation is covered in the International Nursing Association for Clinical Simulation and Learning, (INACSL), Standard on Simulation Design and Criteria 6. It seems logical that when speaking of simulation as an experiential learning tool, anything that enhances the reality of the learning environment is supportive of the learner's experience. The appropriate level of authenticity and realism can contribute to the degree of the engagement of the learner in the simulation, and that in turn can enhance the learning. MOLIDGE, then, is one more tool that the educator can use to enhance the reality of the learning environment. Simulation Teaching Tip 9.1 Taylor et al. Taught dermatologic conditions to nursing students using the nursing process, evidence-based treatments, transmission-based precautions, and teamwork. The conditions were simulated using MOLIDGE and the students had a positive active learning experience. Caution should be exercised though, as improperly done MOLIDGE can detract from the experience. The choice to use or not use MOLIDGE should be driven by the objectives and design of the simulation and not solely by the expertise of the MOLIDGE artist. Makeup and props used for their own sake or to surprise or deliberately confuse or trick the learner will not support the learning outcomes and may send the learners down a false path by providing incorrect cues or information. This is not to say that MOLIDGE cannot be used as a distractor, increase noise, or distraction to add a higher level of difficulty to a scenario, but just that caution should be used. In fact, the use of varying complexities of MOLIDGE can quite nicely adjust the presentation to create several different versions of the same scenario. For example, altering the amount and consistency of wound drainage, leading the learners in one case to deal with an uncomplicated postoperative wound and in another with a grossly infected one. One must remember to match the need and type of MOLIDGE with the learning outcomes and design of the scenario. Simulation Teaching Tip 9.2 A word of caution. This is quite a captivating component of simulation, and the more that you find yourself involved with MOLIDGE, the more tricks you will collect and the larger your makeup kit will grow until you find yourself pushing it around on a cart. Basic MOLIDGE supplies. Assembling a good, basic MOLIDGE kit does not have to be time-consuming or expensive. It is best to start small and keep the kit consistent with the state of one's MOLIDGE skills. In the beginning, you may only be focusing on one or two items or appliances, such as a few application sponges, brushes, and a stipple sponge, a color wheel or two of makeup bruises and burns color palettes, which are a good start, some glycerin and water, the base materials for sweat, a pre-molded commercial wound in the beginning, some sweat, vomit, blood, and a wound or two may be all you need. Simulation Teaching Tip 9.3 An easy recipe for sweat or diaphoresis is to mix approximately 1/3 glycerin and 2/3 water by volume in a bottle with a spray attachment. This allows easy application on either standardized patient, SP, actors or mannequins. The more glycerin used, the more the solution will bead on the skin. Some experimentation may be needed to get a mixture that works just the way you want it to. As a caution, glycerin does tend to build up and get gooey and sticky if not cleaned thoroughly at the end of the day. Soap and water are usually all that is necessary for cleanup. As always, Care should be taken around the eyes when working with actors. Table 9.1 contains a short list of some equipment you might need. As experience increases, the materials used to create injuries and illnesses become more varied. Halloween stores, theatrical supply stores, online stores, makeup counters, drugstores, etc. Table 9.1 suggested basic supplies for a moldage kit. Supplies: makeup, a bruise wheel and burn wheel, from Halloween stores, theatrical supply stores, online stores, makeup counters, drugstores, etc. Sponges, application. Supplies: sponges, stipple, cotton-tipped applicators, lots, makeup brushes, inexpensive to start, liquid latex spirit gum cold cream, glycerin petroleum jelly tongue depressors, lots, stage blood, both thick and thin cleanup products, baby wipes. Tissues. Advanced materials may include liquid latex, exercise caution regarding potential allergies, silicone, both as pre-made purchased wounds as well as silicone adhesive used to assist in application, gel effects, special effects grade gelatin materials, modeling wax, soft sculpting wax to create three-dimensional wound representations. Preparing substances. When trying a new product, be sure to review its properties and characteristics before using it in an actual simulation. Working with a platinum silicone rubber compound is quite different when compared with a liquid latex preparation with regard to setting time and compatibility with plastics. Whatever you choose to work with, time should be set aside well in advance of the event to allow for familiarization with the product and the techniques needed to produce a realistic result. Substances that need time to dry or set may change your preparation timeline. Moldage of the mannequins may need to be started hours or even days ahead of the simulation event. If using actors, in addition to the need for more time for application, new materials require a reassessment of sensitivities and allergies. The time to find out that the blood does not run correctly, or that the pus is the wrong color, or that the adhesive you chose makes the actor itch and break out in a rash is not when students are in the scenario. Gauging the effect of moldage in a scenario is part of the testing process that should be done with any new or revised scenario. Design. Moldage for standardized patients. Using moldage with an SP can produce a greatly enhanced learning experience. A natural conversational interaction with a person as a patient coupled with properly applied makeup or an appliance can produce a very realistic environment. As Garg noted in a study of second-year medical students, simulation education improved learners' ability to correctly recognize skin lesions as well as retain clinical skills longer. The quality of the makeup used can have an impact on this process. Generally, the better the makeup or appliance, prosthetic, the better the result. Simulation teaching. Tip 9.4. As you are learning moldage techniques, remember to take pictures of your work. This will show you your progression and, we hope, your improvement. At times, a static picture and quiet reflection by the moldage artist can reveal inconsistencies in technique as well as outright errors. In addition, this process will build a portfolio of your work as well as provide a reminder of past solutions to moldage challenges. Makeup. Although it is generally true that makeup used in simulations does not need to be expensive, a modest increase in investment can have a positive impact. A higher quality of theatrical grade makeup from manufacturers, such as Ben Nye or Marin to name but two, will produce more consistent results and be easier to work with. Frequently, companies such as these will package makeup in wheels or stacks that have colors grouped for specific purposes. Bruise or burn wheels, for example. This makes the challenge of choosing the correct colors for the desired illness or injury easier. Makeup that is designed and tested to be used on people can also have a lower risk of allergic or sensitivity reactions. Quite a few of the commercial products are manufactured with this in mind, but it is always prudent to check using small amounts and allowing time for any reaction. Good quality makeup can also be obtained from obvious sources of makeup counters and drugstores. However, at times, color selections for illness and injury can be a bit sparse. Although there are many good quality sources of makeup available, determining what works best requires trial and error, and in the end choices are frequently made by personal preference. The application of moldage on a live person will produce more satisfactory results, mostly because makeup blends better on the skin of the actor, and this process allows for more natural coloration and appearance. Materials that are designed for use on the skin work best in that environment. SPs are favorable to work with for several reasons. Generally, it is easier to produce more realistic results. Makeup blends more easily and consistently. Most human-approved adhesives work better. SPs can be taught to care for or refresh the makeup, shortening the reset time between encounters. They can assist with cleanup and removal of appliances. The following are some drawbacks to working with live actors. They move, sometimes a lot. They must go to the restroom, sometimes a lot. They may have allergies. They are sometimes fussy. It is sometimes difficult to get them to sit still for hours. It can be frustrating for the mollage artist if, after an hour of constructing a realistic wound, the patient returns from the restroom and states that the wound just fell off. Patience is one other key ingredient that should be stocked in any makeup case. Figure 9.3. 9.3 states the application of mollage to a live person will produce more satisfactory results. The makeup blends better on the skin of the actor, allowing for more natural coloration and appearance. Mannequins and makeup. Mollage for human patient simulator. Applying mollage to mannequins can be quite a challenge and produce widely varied results, especially when one compares the results achieved with live actors. The variation of the types of plastics that are found in the construction of most mannequins makes it difficult to have a standard approach to the application of makeup or appliances. Some of the issues encountered when working with mannequins and makeup include: blending of the makeup is more difficult and the results look less realistic at times. Simulation teaching tip 9.5. Recycling of old mannequin arms, legs, and so on can produce parts with wounds that can be swapped out after the session. This can also help with the use of adhesives as well. If the limb will be reused to display similar wounds, permanently bonded appliances can be left in place. Some types of makeup can stain easily. This calls for all newly used makeup to be tested on a sample mannequin part or hidden area in advance. Generally, the softer and more porous the plastic, the greater the chance that staining may occur. When attaching appliances, some may not fit well unless specifically made for use with the mannequin in question. A concern that many people have when using makeup on mannequins is the fear that it will stain or permanently mark the mannequin. Although this is a valid concern, much of the higher quality makeup is usable with mannequins. Of course, the mannequin's manufacturer recommendations should be followed to take the most care. Cautious testing in an area that would not be seen if there is staining can produce favorable results and show which makeup can best be used. Figure 9.4. Testing on the reverse of the mannequin's chest skin or behind a removable leg pad or skin and then cleaning the area not only lets you know how the makeup behaves on the plastic, but also what is the best product to use for cleanup. Another problem is the compatibility of the plastics with both the makeup that you are using as well as with the different types of plastics and adhesives that are used together. Care must be taken when combining plastics of different types, as some will inhibit the curing of some adhesives, leaving the appliance sliding off the mannequin. In addition, not all adhesives are created equal and stick to all plastics. One solution is to use a sheet of plastic material as a base, especially if it has some adhesive properties. A clear occlusive dressing comes to mind. At times, the challenge is finding an adhesive that has good sticking ability to keep wound appliances in place, but not so good that it forms a permanent bond, or else you may end up with an unintentionally dedicated trauma mannequin. Some mannequin manufacturers will produce wound sets that will fit onto their mannequins. These may not look as realistic as they should, and there is expense involved, but the ease of use may outweigh the investment. The realism can be enhanced with some makeup and a drizzle of blood. And if the part is repeatedly used in the same type of scenario, minimal staining may not be an issue. As with all mollage, some experimentation is needed to be sure what you implement is what you intended. Special effects basics. Creating props and setting the stage. Many items needed for a simulation may be created as well as purchased. One is only limited by resources and imagination. Sometimes simply changing the mannequin's clothes, moving it from a bed to a stretcher, and adding a code cart will add the impression that care is being delivered in an ed. In the movie industry, this is called setting the stage or dressing the set. This should not be a daunting task or involve a great expense. Most often, the supplies that you need you can find in your environment or around you with only a bit of looking. A good source of wardrobe items for your mannequins may be only as far away as the local thrift store or an email to your faculty and staff requesting old cast-off clothing. Perhaps a short trip to a local beauty supply store or a wig shop for some new hair will really change the characteristics of the patient. Add a pair of glasses, a sweater, and a purse, and Mrs. Jones begins to emerge. Empty cardboard boxes painted gray and black can make passable cinder blocks that can be used for the wall that will fall on the SP at the end of the disaster, providing yet one more victim. The best part is that they fold flat for storage, ready for use in future scenarios. Foam blocks painted gray will work as well but are more challenging to store. Making props and scene decorations can be fun and creative. Using props to add realism to the scenario makes it a much richer experience for the learners. All components should support the story and be logical additions that reinforce the reality for the learners. Props, however, should not get in the way or cause distractions, causing the learners to commit errors due to the incorrect representation of the scene. Therefore, it would seem that we need to construct completely realistic environments that use only real equipment and materials. This is not necessarily true. A fabricated prop can be valuable and inexpensive if it gives the proper and correct clue or clues to the learners in the simulation. A cardboard box with the image of the front panel of a fetal monitor and actual monitoring strips pulled from the opening can assist the suspension of disbelief and provide information that the learner needs to navigate through the scenario. With props and set dressing, as with Moldage, if the learner spends more time trying to guess what they are looking at than getting useful information to use in the scenario, you have missed the mark and quite possibly the intent of the scenario design. Simulation Teaching Tip 9.6. When designing the scenario, the characteristics of the room should not be forgotten. It is as important to moldage the room as it is to moldage the patient. Striking the set, cleaning up and resetting the session is not over until the cleanup is done, and this can be one of the more challenging aspects of using moldage. It is wise to check the materials used in moldage beforehand for ease of cleanup. Figure 9.5. Essentially, striking the set is a theater term that means to put the performance space back to the condition in which you found it. This means not only cleaning the mannequin and the simulation space, but also putting all the appliances and props away. If a logical and protective system is designed to store these materials when not in use, it will extend the useful life of the items. For example, the usable life of silicone or latex molded wounds can be extended if they are cleaned properly, removing excess adhesive and makeup, and stored in an airtight container with a light dusting of talcum powder. Proper care of moldage supplies will ensure they will be available for many more uses. Props and wardrobes of both the mannequin and the SP should be stored in a way that will make them easily accessible for the next session. One method is to create a scenario container to house all the essentials for that scenario. This will help keep all materials in one place, and if the storage container is portable, it may be taken to the location of the mannequin or actor during setup. Cleaning materials needed for after the sessions are not much different from those needed for daily cleanup in the simulation laboratory. Sponges and non-bleach containing wipes are staples. Attention should be paid to items that can be used on humans, gentle cleansing wipes and makeup remover, cold cream, and the like. Mannequins may need some additional help, adhesive removers and alcohol, for instance. Some common needs for cleanup are as follows. Baby wipes. These are particularly helpful when working with actors and for keeping your hands clean during the makeup process. Alcohol. Any strength is good, but if you are working with liquid silicone compounds, you will need at least 90% as it does a better job of cleaning up the unreacted material. Adhesive removers. When using adhesive removers, start with the mildest form before using the acetone-based removers, as these may remove the coloring on the mannequin. Makeup remover or cold cream. This does work best on SP actors and can help with the cleanup. Some products can be used on mannequins as well. It is important to follow the mannequin manufacturer's guidelines on products used for cleanup, and it is always a good practice to test all cleaning materials on a small non-obvious area of the mannequin before large-scale use. Sometimes it is a good idea to put a barrier material on the mannequin to make cleanup of makeup easier. Plastic wraps or adhesive clear dressings work well. Some experimentation may be needed to see what method fits your expertise and budget. Summary: moldage is a great art to add to simulation and to encourage realism. Moldage is an art that calls for creativity, practice, and developing authenticity. Moldage can be applied to both the human simulation instrument and the environment to better assist healthcare learners in understanding patient care. Chapter 10: Simulation Principles, Practice, and Methodologies for Standardized Patient Simulation. Standardized patients, SPs, were introduced into medical training in a limited fashion in the 1960s, but it took almost 30 years for the concept to enter the fields of nursing education and research. Initial objections toward using SPs included the high cost of implementation, hiring and training SPs, videotaping experiences, the so-called Hollywoodization of the hard sciences, and a skepticism that an actor, not a trained healthcare professional, could correctly help assess learner skills. Yet SPs are not necessarily all trained actors, and they have been found to have lower levels of unreliability and bias than nursing instructor observation or preceptor input. Overcoming this original skepticism and proving their usefulness reliability, and consistency in a healthcare education setting. SP experiences have greatly increased in popularity, and for good reason, because they offer a safe environment for learners. The realism of the SP encounter relies on effective case writing by the Certified Healthcare Simulation Educator, CHSE, and precise training by either the CHSE or the specific SP trainer. The training is based around measurable learning outcomes, but not every single question or reaction that the SP might encounter during a day of work can be preemptively trained for. However, an SP can be given guidelines and direction and may even use their own personal background in some situations. A well-trained SP will react naturally, determined by the role they are playing that day. It is also important that the CHSE keeps the personality, attributes, and capabilities of the SP in mind when writing the scenario. It would not make much sense to write the case with a gender-specific problem if the available SPs are not all the same gender. Flexibility is another benefit of working with SPs. During an SP experience, learners practice communication, history-taking, and physical examination skills. Different cases may emphasize certain illness manifestations, complications, or ethical challenges. The SP can even be instructed to emphasize their attitudes toward health professionals. This attitude could range from a healthy skepticism to mild verbal aggression to contempt. The SP can be trained to propose a number of challenging situations that the learners might face with a real patient, and the entire group of learners can undergo the same experience due to the consistency and standardization provided by the SP. According to the Society for Simulation in Healthcare's, SSH's, Healthcare Simulation Dictionary, SPs are also referred to as standardized participants or simulated participants. Standardized patient case development. The SP case development begins with identification of the simulation objectives or educational goals and the setting of the simulation scenario. It is very important to be clear on the setting of the scenario to help learners understand their role and what is expected of them during the simulation scenario. In an SP simulation scenario, the SP can have the role of a symptomatic patient, a non-symptomatic patient, a psychiatric patient, an emotionally hysterical patient, a severely depressed patient, or any type of patient you need. The SP can also portray a family member. With the SP being a real person, the sky is the limit, anything is possible. A well-written simulation scenario includes clear objectives, training materials, including a detailed script, and medical details that are clearly and appropriately described for the SP's use, along with enough background to describe the complexity of the patient. There are many different templates available to help develop your SP scenario, and it is important to find which template works best for your simulation center or institution. Evidence-Based Simulation Practice 10.1. Davis et al. Investigated templates and protocols that enable standardized patients, SPs, to accurately and consistently adopt these roles. The researchers conducted a meta-analysis examining published templates and protocols used in medical, nursing, allied health, and veterinary medicine disciplines. Timing of the simulation scenario. When planning the simulation scenario, you must consider the timing of the scenario. This is important for planning and scheduling the participants for the experience. The entire simulation encounter includes the following: A. Pre-simulation briefing. B. Total time the learner has to work with the patient. C. Time for the patient to complete the learner observation checklist. D. Time for the patient to provide feedback to the learner. E. Time after the encounter if you want the participant to do documentation, or a survey, or a post-ist. And F. Time for the SP to prepare for the next learner. Many SP simulation scenarios do not include anything after the encounter. So, for example, if you are planning 15 minutes for the pre-brief, planning for the learner to be with the patient for a maximum of 15 minutes, and you are going to allow 5 minutes for the SP to complete the checklist, 7 minutes for the feedback session, and 3 minutes for the patient to prepare for the next learner, each total encounter will take 45 minutes. The following, Exhibit 10.1, demonstrates an example of the time management needed for an SP scenario. Exhibit 10.1 Time management for a standardized patient scenario. Example 1 Pre-brief, 15 minutes. Time with patient, 15 minutes. Checklist time, 5 minutes. Feedback time, 7 minutes. Turnaround time, 3 minutes. Total encounter time, 45 minutes. Example 2 Pre-brief, 15 minutes. Time with patient, 30 minutes. Checklist time, 10 minutes. Feedback time, 15 minutes. Turnaround time, 5 minutes. Total encounter time, 75 minutes. This will assist you with planning the schedule of the simulation experience, Also taking into consideration the number of simulation rooms you have available and the number of learners who have to complete the simulation experience. Identify the setting. The setting is a very important part of scenario planning. Where is your scenario taking place? Is it in a physician's office, in an ED, in a medical surgical unit, in a critical care unit, in the community, in a patient's home, in a clinic, or in a surgical family waiting room? Ideally, the simulation room should depict this environment, or if this is not possible, a sign should be clearly posted to remind the learner of the environment where the scenario is taking place. The role of the SP must be clearly identified. The SP can portray a patient, a family member, a learner, or any other role imagined. Standardized patient position and attire. As part of the scenario development, you must also identify the position of the patient when the learner enters the room and the attire the patient should be wearing. Position examples. Sitting in the chair, sitting on the exam table, walking back and forth in the room, pacing anxiously in the room. Attire examples. Wearing a patient gown. With underwear on, wearing a patient gown. No underwear on, wearing regular clothes, wearing a gown with pants on. Evidence-based simulation practice 10.2. Bond et al. Examine the influence of high-value care and focused virtual standardized patients, SPs, on learner attitudes toward cost-conscious care, performance on subsequent SP encounters, and the correlation of virtual SPs' performance with educational outcomes. The researchers found that high-value care didactics combined with virtual SPs or SPs positively influences attitudes toward cost-conscious care. Learner's role. The role of the learner should also be very clear. Is the learner working in a new graduate nurse role, a physician role, a physician assistant role, or an advanced practice nurse role? The learners should be reminded of their roles in the simulation instructions and to observe the door sign so that they function within their scope of practice. Identify the focus, objectives, or outcomes. The SP simulation scenario has to have a clear focus and objectives. Is the scenario going to be based on a specific medical diagnosis, asthma, congestive heart failure, shortness of breath, abdominal pain, a mental illness, psychosis, hearing voices, psychosocial challenges, depression, anxiety, ethical situations, do not resuscitate, DNR, organ donation, assisted suicide, or another scenario? This selection will be the basis for writing your case. It is important to include clear information about the selected condition/situation highlighted in the case for the education of the SPs. Next, what are the objectives or educational goals for the learners completing the scenario? For example, if you are working with undergraduate nursing learners, the objectives could include the following. Obtain a complete history from the patient. Complete a focused physical exam based on the patient's diagnosis. Provide patient education based on the educational needs identified during the time with the patient. If you are working with medical learners or advanced practice nurses, the objectives could include the following. Obtain a complete history from the patient. Complete a focused physical exam based on the patient's diagnosis. Identify the patient's diagnosis. Order diagnostic tests as appropriate. Provide the patient with appropriate information and plan of care. The objectives are also linked to the specific course, educational program, or clinical unit of the learner. It is important that the learner is aware of the required objectives or educational goals of the simulation experience. Standardized patient questions and answers. The SP case should also include any questions the learner may ask during the scenario and the response the patient is supposed to provide to the learner. Any questions specific to the diagnosis or condition of the patient will need a specific answer, such as symptoms and medications. For other questions that do not have a direct impact on the direction of the scenario, you may have the patients use their own information and not require a specific answer. Depending on the complexity of the case, one must be realistic as to how many specific lines or questions the SP can memorize and portray. Door sign. The door sign is the sign that will be posted outside the simulation room to provide information to the learner. Exhibit 10.2. The door sign should include the following. Information about the scenario. What you expect the learner to do in the scenario, how much time the learner has to complete the scenario, reminder to refer to the patient chart if one is included as part of the scenario. Exhibit 10.2 Door sign examples. Door sign example 1 Mr./Mrs. Pat Foles came to the ED with complaints of increased thirst, increased urination, and hunger, and is now admitted to the medical surgical unit. You have 45 minutes to complete a history, focused physical exam, and appropriate patient teaching. Door sign example 2 Mr./Mrs. Pat Wentz came to the ED with complaints of a severe headache and is now admitted to the medical surgical unit. You have 45 minutes to complete a history, focused physical exam, and appropriate patient teaching. Please refer to the patient chart for additional information. Door sign example 3 Mr./Mrs. Fran Victorino has been in the hospital for the past week and was diagnosed with HIV. The patient is preparing to be discharged from the hospital. You are to give the patient discharge instructions, including the important steps to prevent transmission of HIV to others, such as measures for safe sex and so on. The discharge instructions have already been prepared for you by the doctor and are provided in the patient chart. You have 15 minutes to complete this. Encounter. Evaluation checklist. The evaluation checklist is a detailed checklist of what you expect the learner to do during the scenario. In most institutions, this checklist is completed by the SP immediately after the completion of the scenario and before the patient provides feedback to the learner. Depending on how you decide to design your checklist, you can choose to separate the checklist items by categories, such as communication, physical exam, patient teaching, diagnostic tests, or other categories. If a checklist item is subjective, it can be helpful to put a descriptor to provide information on how to evaluate that checklist item. For example, in Table 10.1, you will see the checklist item Good Eye Contact, with the descriptor explaining that if the learner has good eye contact at least half of the time they will get credit for that checklist item. It is also important to remember that the longer the checklist, the more time you have to allow for the SP to complete it. Table 10.1, example of evaluation checklist items. Communication introduced self, name and title. Physical exam. Washed hands before the examination. Check the patient's identification band. Explain what they were doing with each step of the exam. Good eye contact, 50% of the time or help to position the patient greater, was professional in manner, spoke clearly in terms the patient can understand. Maintained modesty during exam. Active listener, checked blood pressure in both arms, asked the patient's age or date of birth. Asked about the patient's marital. Checked blood pressure sitting or lying down, checked blood pressure standing. Communication. Physical exam. Status. Asked about the patient's work history, asked about previous hospitalizations, asked about allergies, asked about medical history, asked about current medications, counted the pulse, counted the respiratory rate, asked about history of chest pain, asked about history of palpitations, asked about smoking history. Listen to the heart in at least 4 places on skin, listen to the lungs in at least 4 places, 2 pairs, anterior and posterior on skin. Asked about alcohol history, asked about diet, asked about exercise. Asked about stresses in life. Created an atmosphere that put the patient at ease. Simulation teaching tip 10.1. If there is a checklist item that has more than one part, where a learner could possibly do one part correctly and one part incorrectly, such as listening to the lungs, it is helpful to separate that into 2 separate checklist items, as you will see in the example checklist in the following text. Learner evaluation criteria and passing score. There are many ways to evaluate the learner checklist items. Some of the common evaluation methods include done/not done/nah, done/not done/done but not correctly. Likert scale rating. Your simulation program may select one way to evaluate all of your simulation experiences or may be different based on a specific program or course. If the simulation is a high-stakes testing simulation in which the learner has to achieve a specific score to pass, you must also pick a passing score. Many programs will pick the lowest score for a full grade of C at their school, or the specific score might be mandated by your licensing agency. Another aspect to consider is the value of each checklist item. Are the checklist items of equal value, or are some checklist items worth more points than others? You can also identify specific patient safety checklist items that are critical. If the learner misses that checklist item, they automatically fail or have to repeat the experience, such as verifying the patient's identity or checking the identification band. Exhibit 10.3 demonstrates 3 SP simulation cases, including the evaluation checklist. The first and third cases are ethical dilemma cases, while the second case is a hypertension case. Standardized patient feedback. Another important aspect of case development is planning for the SP's feedback at the end of the simulation experience. A common type of feedback is for the patient to provide interpersonal feedback on how the learner made them feel as a patient. The feedback can either be very specific or general. See Chapter 18 for extensive information on SP feedback. Examples of an SP case template and a blank SP case template are provided in Exhibit 10.4. Orientation, education, and training of standardized patients. The SP case scenario written by the CHSE is explained to the SPs during the SP training session prior to the simulation experience, and ideally in advance of the day of the simulation experience. If the training is taking place on the day of the simulation experience, it is important that the learners do not interact with the SPs before the experience to keep the level of realism as high as possible. Depending on the type of SP experience the instructor has crafted, training for a standardized patient involves, for example, learning what history questions to listen for or how the physical examination should be done. Along with describing the direction that the case is supposed to take, the CHSE will also explain the objectives of the scenario. Simulation Teaching Tip 10.2. If you are new to writing standardized patient, SP, case scenarios, when you have finished your first case and start your next case, just do a save as and start with your original case as a baseline. The training of the SP begins with the specifics of the simulation case, including the following: name of the patient, role of the patient, family member, etc., setting of the scenario, for example, medical surgical unit, ed. Background of the scenario, i.e., why the patient came in, the information the learner will know before beginning the scenario, such as the door, sign, an opening line or lines to use to begin the scenario. If included in the scenario, challenge question, i.e., a specific question about the condition or chief complaint about the SP's condition if included in the scenario, training questions the learners might ask and what answer is required, checklist items, feedback. Along with the education about the case itself, the SP must also be clear on the learner checklist and how it should be completed. After the scenario, the SP will complete the learner checklist prior to the feedback session. Through observation, the SP's completion of the checklist contributes to the learner's evaluation, which is formally done by the CHSE. In some institutions, the faculty or simulation educators may complete the checklist. Simulation Teaching Tip 10.3. When using SPs for simulation learning experiences, it is best to use a consistent set of actors who work routinely at your institution because they become part of the culture of learning at your educational organization. After reviewing the case and the checklist, the SP can ask questions, discuss strategies, or practice through role-playing. The goal of the SP's training and education on the case is that they enter the role so carefully coached that the simulation cannot be detected by a skilled clinician. Standardized patient's role in learners' evaluation and feedback. For an SP scenario, the SP can be clearly instructed on how to complete the learner checklist. The SP's training is directly related to the accuracy of the SP's completion of the checklist. In addition, for the results of the checklist to be valid, how the checklist is created is crucial to its validity and reliability. As mentioned previously, the SP's completion of the checklist contributes to the learner's evaluation, which is formally done by the CHSE. SPs have a unique role in post-scenario feedback. The feedback time can be a heightened time of awareness for the learner, and the information provided to the learner at that time can make a lasting impression. Many learners, after completing the SP simulation experience, state, "I will never forget what that patient told me." Or the SP feedback was the best part of the experience. The role of SPs in healthcare simulation education is depicted in Figure 10.1. Hybrid simulation using standardized patients. As confederates, many simulation scenarios find it optimal to combine both the human patient simulator, HPS, and the SP in a simulation scenario. When SPs are used in this fashion, the simulation is referred to as hybrid simulation, or the SP can be referred to as a confederate in the simulation scenario. See Chapter 11 for extensive information on hybrid simulation. The SSH's Healthcare Simulation Dictionary defines a confederate as an individual who during the course of the clinical scenario provides assistance in locating/troubleshooting equipment or may provide support for participants in the form of help available. Standardized patient simulation during a pandemic. During the pandemic, many organizations converted their SP simulation experiences to virtual experiences using one of the many available virtual software platforms, such as Zoom, Skype, GoToMeeting, Microsoft Teams, and others. This format worked well for individual learners and groups of learners. If there was a group of learners, they could be moved into individual breakout rooms along with an SP for the simulation experience. Summary: SPs are a very important aspect of healthcare simulation education. To have a successful SP simulation experience, the case development must be accurate and comprehensive. In addition to the carefully developed case scenario, SP training is equally important. The SP's completion of the checklist must be accurate and consistent. The SP's feedback has to be carefully structured because it can have a lasting impression on the learner. SP simulation provides the opportunity for the most realistic simulations in a safe environment. In the future, SP simulation will be an expected standard in every simulation program. Chapter 11, Hybrid Simulation. Introduction. Aristotle's maxim about how complexity is created from simplicity holds true for hybrid patient simulations, the use of two or more patient simulation modalities simultaneously or sequentially to enhance the fidelity of the experience. For example, when mannequin-based simulators are combined with simulated participants, there is an advantage gained that neither of the two could offer alone. Hybrid patient simulations combine two or more simulation modalities, learning, strategies, and professionals into a powerful platform for teaching and assessing clinical competencies. This hybridization allows for a mixing of levels of technology and fidelity while also considering the cost and accessibility of modalities and other resources. However, the complexity of combining multiple simulation modalities, from the artificial to the human, requires planning and cooperation. Simulation is an aid to the imagination for both the simulationist and the learner. It allows us to create, populate and activate possible futures, and explore ramifications of these developed scenarios. The willful suspension of disbelief, a concept described by poet Samuel Taylor Coleridge, is directly applicable to simulation learning. If writers could combine human interest with a semblance of truth, then readers could overlook a story's implausibility. Indeed, the first task for simulationists is to get learners to buy into a scenario even though all learners know it is a construction, a representation of reality. Hybrid patient simulation is an approach that combines various elements of constructed reality, live, computerized, and mechanical, used in an environment that looks and sounds real. Live participants can be incorporated into a scenario and be given distinct roles to create that semblance of truth, which makes learning compelling. Foundations of patient simulations. The use of simulation to teach essential skills is widespread and deeply embedded into human culture. We seem to be hardwired to substitute the authentic with constructed reality. From infancy, we practice sucking and rooting reflexes through a pacifier, essentially a part task trainer that simulates a mother's nipple. The military has used war simulation for millennia. The ancient Hindu game Chaturanga and the Chinese Go were used to practice strategic thinking, and large-scale war games replicated battlefield conditions. Roman Jewish historian Flavius Josephus notes that Roman general Tiberius conducted war games that were bloodless battles to prepare for actual battles that were bloody drills. Aviation has long been at the forefront of using simulation to teach core competencies in our era, and its use has been a model for healthcare simulation. The Wright brothers used a Kiwi bird simulator in 1910 to teach flight control using a defunct Wright Type B flyer. The Antoinette trainer was a barrel split in half with short wings, allowing students to practice banking and turning, while an instructor pushing or pulling on the wings simulated turbulence. Such simulators were hybrids combining task trainers with an instructor acting as a simulated participant, that is, an individual who plays a role in a simulation to add realism and to move critical action forward. Human patient simulation today has two roots: computerized mannequins and simulated participants. Sim1, the first computer-controlled mechanical patient simulator, was developed at the University of Southern California in 1967 by a team led by Stephen Abramson and Judson Denson. In the late 1960s, the Harvey simulator, a hybrid between a cardiac task trainer and a computer-enhanced mannequin-based simulator, integrated the bedside findings and realistically reproduced both common and rare cardiac diseases. Simulated participants, introduced by Howard Barrows in 1963 at the University of Southern California, have long been used to teach clinical skills and are the foundation of performance-based assessment. Evidence-based simulation practice 11.1. Downer et al. Studied the effects of using standardized patient simulation compared with didactic learning in improving the skills and patient comfort among medical students, N=94, using a single blind, randomized, controlled design. The findings supported simulation improved communication skills and empathy when compared with didactic learning alone. Typology and modes of simulation. Simulations can be divided into four types. Live, learners interact with real systems or people, for example, evaluating the patients, as simulated participants, or customer exercises in which actors, playing patients, assess the reception of office staff. Virtual, learners interact with simulated systems, for example, training on a computer. Based virtual reality, VR, Surgical simulation. Constructive, learners interact with simulated systems and simulated people. 4. Example, operating room team training using VR in which simulated participants substitute for actual participants. Hybrid, this type of simulation combines live, virtual, and constructive modes of simulation in different combinations. There are many modalities available to simulationists that may be combined to create hybrid simulation-based educational experiences. The types of simulated patients used by healthcare simulationists for teaching and skills evaluation include part task trainers, humans, standardized patients and simulated participants, computerized mannequins, virtual, computer-based, mixed/extended reality, etc., patients. Evidence-based simulation practice 11.2. Bennett et al. Completed a literature review, N=57, about the use of different types of simulation for occupational therapy, OT, education, and found that within the OT curricula simulationists have used the full scope of simulation modalities, including written case studies, 22, standardized patients, 13, video case studies, 15, computer-based and VR cases, 7, role-play, 8, and mannequins, part task trainers, 4. 10 studies used hybrid simulation learning experiences. The review indicated that simulation was being used effectively in education. The following summarizes their utilization and features, with examples of combining the modes into hybrid simulations. Part task trainers. Resusci-Anne, a plastic mannequin, was introduced in 1960 to teach CPR and thus began the advent of commercially available part task trainers. Today, a wide variety of trainers are available to practice airway management, vascular access, echocardiography, cardiovascular assessment, and many other tasks. Simulation teaching tip 11.1 part task procedures can also be practiced using common objects, for example, using an orange to practice injection or using a pig's foot to practice suturing. Additionally, increased access and ease of use of silicone molding techniques and three-dimensional printing have significantly increased options for low-cost and readily available part task trainers and other do-it-yourself simulation solutions. Part task trainers replicate the anatomy, for example, the skin, head, upper and lower extremities, esophagus, and thorax, and in some cases the physiology of a part of the human body. This allows learners and professionals to practice specific tasks or technical procedures without harming or hurting an actual patient. Parts of the whole task are used to prepare the learner for the whole task. Part task procedures can improve learning efficiency because a specific skill can be practiced multiple times until mastered. They can also reduce training costs because the learner would not participate in a full simulation exercise until a particular skill is mastered. Examples of part task trainers, which are hybrids, include starting in 4-line on an arm attached to a simulated participant, suturing a leg wound attached to a simulated participant, using a pelvic trainer with a simulated participant, performing a urinary catheterization on a part task trainer with a simulated participant, doing a rectal exam on a part task trainer with a simulated participant. Human patient simulations. SP is a commonly seen abbreviation in the healthcare simulation world. Depending on context, this may refer to standardized patients, simulated patients, or simulated participants. Commonly, standardized patients refer to individuals who have been specifically and particularly trained to portray a specific patient reliably and reproducibly with a standard presentation, often for assessment purposes. Simulated patients are often given more leeway in their portrayal, with specific elements required to simulate a specific situation or condition. Finally, simulated participants are non-patient actors within a simulation-based experience. These may be any number of other people needed to enhance the fidelity and continuity of the simulation. Although standardized patients are used mostly to teach and assess individual clinician competencies, they can be combined with simulated participants who portray non-patient roles. Also, simulated participants are increasingly incorporated into mannequin-based hybrid scenarios. They are scripted into a simulation to add realism and provide additional challenges and information to learners. They can portray, for example, a patient's mannequin, family member, a healthcare team member, or any other role required by the scenario. They can be programmed to portray distinct personality types and emotionally complex and nuanced roles that correspond to the learning objectives of a learning module. Simulated participants can also be used to assess skills, for example, to determine whether procedures are used in a correct and timely manner, assess team communication, and provide feedback during the post-encounter debriefing. Simulated participants, like standardized patients, require training for whatever roles they take on. The following are examples of how to use simulated participants with hybrid simulation. Learner interacts with a standardized patient, and a simulated participant is a healthcare team member. Learner must provide bad news to a distraught family member after examining a standardized patient who portrays an end-of-life patient. Mannequin-based simulations. Mannequin-based simulations are often used for training and assessing healthcare teams. The advantage of using mannequin-based simulators is when the patient condition is dynamic, particularly critical, or requires significant and often invasive interventions. Depending on the model, these computerized, mechanical, often high technology and high fidelity mannequins represent patients at various developmental stages, infant, child, adult, and are used for different purposes, for example, anesthesia training, birthing simulations, and with programmable cardiovascular, respiratory, and neurologic responses to clinical interventions. Depending on the model, the ingenuity of the simulation operations specialist, and the condition of the patient, all mannequins can have a voice. Talking through a microphone and listening through headphones, the patient's voice is sometimes that of a standardized participant placed at a distance, for example, behind a one-way mirror, and whose role is to answer questions as a patient would. Examples of hybrid simulations with standardized patients or simulated participants with mannequins include but are not limited to: learners interact with both the standardized patient and the mannequin because they are portraying the same patient at different stages of the scenario and states of patient acuity. Simulated participants may be used as a mannequin's voice, a family member, a healthcare team member, other bystander. Extended/mixed reality and computer-based simulations. Computer-based simulations using videos, drawings, and animation to represent a patient have shown promise in developing clinical reasoning skills. Learners interact with the patient by asking questions, typing or speaking, by viewing data from monitors, labs, or X-rays, and by performing diagnostic or therapeutic actions, typically by making choices with the mouse. At a much higher technology level, VR systems allow learners to become immersed in a computer-generated environment with individuals or groups of individuals. One purpose of VR is to immerse the user in a computer-generated environment. Recently, extended/mixed/augmented/VR systems have become much more reasonable in terms of financial and other resource costs. While not yet ubiquitous, their use is far more widespread than even a few years ago. Below are examples of hybrid VR. Chapter 13, Virtual Reality, provides in-depth information on VR, a computer program that simulates the living conditions of a patient before the learner interacts with the simulated participant or mannequin in the simulation laboratory. Use of real-time VR with a group of learners and multiple simulated participants. Augmented reality headset that creates a high-fidelity environment surrounding a simulated participant or mannequin used for specific verbal and hands-on interaction. Any form of extended reality being used to teach and assess clinical decision-making or scene management in a complex scenario. The role of the simulationist in hybrid simulation. Arguably, the most common hybrid simulation involves mannequins and simulated participants. Such hybrids may involve several simulation education roles. However, there is a great deal of overlap in the following functions that may be performed by one or more people with multiple responsibilities. Healthcare simulation operations specialist. Often, this is an individual with advanced skill and/or knowledge in technology, clinical patient interaction, and simulation-based education, and typically an individual with a clinical background, for example, a physician, nurse, or paramedic. These individuals design healthcare team educational and assessment programs, construct mannequin-based simulation scenarios, and participate in debriefing and feedback. Healthcare simulation technician. An individual with both mechanical and computer skills is desirable. The technician works with the specialist to prepare the mannequin for the encounter, troubleshoots the mannequin's technical/mechanical problems, keeps the mannequin in good repair, and occasionally functions as the mannequin's voice or simulated participant. Often, the specialist doubles as the technician. Simulated participant educator. Working with the simulation specialist, the simulated participant educator advises how to use people effectively in a scenario, writes simulated participant training notes, and trains them for the scenario. Psychometrician. This is an individual who designs assessment rubrics and collects, analyzes, and reports performance data. Subject matter expert. This is often an individual with specific experience in clinical Expertise related to the learner and simulation scenario being designed and implemented. Simulationists have several functions in this resource-intensive process, which are outlined here. Stakeholder education. One of the most important roles is to educate stakeholders, for example, learners, clinical faculty, and subject matter experts, about how patient simulations are used as an educational strategy. Learning topics include simulation as an educational strategy, adult learning principles, simulator capabilities, logistics and implementation, developing scenarios, matching learning objectives and modalities, assessing performance validly and reliably, debriefing and feedback. Faculty and professional development can take many forms, for example, seminars, webinars, and discussion of articles. One of the most powerful ways to educate the faculty about how simulation works is to take them through actual encounters, experiencing the simulation, assessment, and debriefing process as the learner would. This step helps the faculty understand the needs of the learners and the strengths and limitations of simulation learning. The faculty need to understand the curricular, technical, and logistical issues involved in developing and implementing simulations to facilitate effective educational programs. These issues become more complicated when developing hybrid scenarios. Simulation venues, where patient simulation takes place, may dictate different processes and expectations. Simulation venues are often separated into in situ and in silico. Simulation-based experiences that take place in the actual patient care setting/environment are considered in situ, while simulations that occur in a more controlled lab environment are in silico. In situ, simulation often requires additional resources and planning. Individuals working in their actual practice environment, in situ, often experience higher engagement due to the higher environmental and conceptual fidelity of the simulation. However, working in this environment often creates a few logistical challenges to the implementation of the experience. Working clinicians in an active environment may be called away suddenly, or the space may be needed for actual patient care. In these instances, training may need to be cut short or canceled suddenly. In situ training is particularly useful for just-in-time training and systems testing. In silico training allows for greater control of the environment and more deliberate scheduling of the space for simulation-based experiences. Depending on the resources available, lab spaces can be made very similar to actual patient care areas, but will always have some element of separation from those environments. This can be useful for training interprofessional groups or more generic and foundational training for early learners, as in medical or nursing schools. The lab environment also allows for training and testing in scenarios that would be very disruptive to actual patient care, such as power outages. In silico training can be more reliably scheduled and reserved, with simulation-based experiences specifically built into the curriculum and more reliable assessment or gatekeeping to different levels of training. Curriculum development of the educational curriculum with its various goals, objectives, methods, and intended outcomes is the first step in developing a program. Done in conjunction with clinical faculty and/or subject matter experts, simulationists determine what skills are best taught and practiced through simulations and at the appropriate learner level. They must decide what simulation modalities are best suited to the educational plan and be creative when the desired modality is not available, lacks fidelity, or is in short supply. Scenario development. Simulation scenarios are vehicles for assessing skills. All simulations are an opportunity to provide learners a formative or summative assessment and help the faculty self-assess the quality of their clinical education. The patient simulation scenario is a plan indicating how a program will unfold, how the mannequin will be programmed or operated remotely, and how simulated participants will be part of the scenario. An example of information provided to a simulated participant to prepare for role portrayal is shown in Table 11.1. Table 11.1. Hybrid mannequin with simulated participant scenario template. Scenario summary. Scenario name. Patient's name, age, and gender. Mannequin. Scenario setting. Condition of the patient at scenario start. Educational plan. O learner level. O program goals. O program learning objectives. O modalities. For example, types of simulators used. O intended outcomes. O challenges to the learner. Simulated participant information. Simulated participants' names and relationship to the patient narrative. Describe the scenario, what the simulated participant will know about the patient's condition at the start of the scenario, how the simulated participant will interact with the healthcare team, and how the simulated participant will act. Patient information, mannequin, list information the family members will be able to give team members if requested. Note, write the answers to the following information as the family member would give it. Avoid jargon. Patient's overall health. Medical history, patients' medications and why taken, surgical history, health risk behaviors. O, exercise. O, diet. O, tobacco use. O, alcohol use. O, substance use. O, other pertinent information. Simulated participant training. Simulated participants can have several functions that require preparation, training, and rehearsal. Scenario notes that guide role portrayal, like simulated participant cases, must be written down and modified as needed. Training on the fly should be avoided, especially when assessing and comparing the performance of groups. All simulation scenarios may have the ability to be standardized, as in standardized test, if the conditions of testing are standardized to varying degrees. Training objective setting, scenario, the vehicle for assessing skills, modality used, timing, equipment, performance assessment and debriefing/feedback. The following list is an outline of required training for simulated participants, depending on how extensive their role will be in the simulation. Portraying a non-clinical role. Simulated participants can be trained for a number of roles, such as a patient, as part of a two-part sequential simulation. For example, a live patient who becomes a mannequin patient, a family member, or other auxiliary role required of the scenario. For example, a bystander in a simulation taking place in the field. Portraying a clinical role. A clinician can enter a simulation as a simulated participant, playing a clinical role they can perform with credibility. This adds verisimilitude to the simulation because the clinician can realistically participate and further the action from the inside out. Simulated participants can also fill in as simulated team members or clinicians, but their participation will be limited to whatever part they can play. Realistically, skills assessment. Simulated participants, both clinical and non-clinical, can be trained to document when procedures are done in a timely and correct manner. For example, correctly intubating a mannequin patient or part task trainer. It is recommended that all charged with this task practice the skill being assessed until mastered, and practice observing, assessing the skill, and remembering it for later documentation during practice encounters. Clinical experience and performance assessment experience are two separate skill domains. Skills/communication teaching assistant. Simulated participants, both clinical and non-clinical, can be trained in specific skills related to patient care. In these roles, the simulated participant may act as a teaching assistant, providing directive feedback in the moment and assisting learners in very specific skills. These simulated participants may or may not have specific clinical backgrounds, but often receive additional training to enhance their ability to assess and guide performance of these specific skills. Most commonly, these are physical exam teaching assistants, PETAs, or genitourinary teaching assistants. Assessing team communication skills. Simulated participants are arguably in the best position to assess team communication because they are participating from within. Their roles may also require them to challenge learners, for example, to be a demanding family member or an incompetent team member. Such challenges are dictated by the training objectives. They are therefore part of their training notes, and they can then judge how well the learners respond to their challenges. Team communication is best assessed using an assessment rubric. Debriefing and feedback. Simulated participants who are clinicians as well as simulation specialists/facilitators are in the best position to explore clinical decision-making issues and identify performance gaps during debriefing. Their clinical knowledge and understanding of the teaching objectives can create a climate of trust and learner engagement. Both clinical and non-clinical simulated participants who have been charged with assessing communication have a role in debriefing communication. Their role may be to challenge learners to maintain both interpersonal and team communication throughout the encounter. Issues of hybrid simulation and patient fidelity. Simulation fidelity refers to the extent to which a simulation or device replicates the environment or a patient's physiologic condition. Fidelity can be broken into several different categories, most commonly conceptual, environmental, or psychological. Each type of fidelity may be reproduced with varying degrees of success. All simulation modalities have fidelity issues, that is, they are more or less realistic, possessing a degree of similarity to the patient, the environment, the concept of the case, and psychologically to the scenario. In general, the more standardized or replicable the simulation is, the less realistic it may seem because of the need to standardize testing conditions for all. One advantage of hybrid simulations is that high and low fidelity elements can be balanced to create the most realistic simulation-based experience with consideration of resource availability, cost, and objective/learner level need. Hybrid simulation provides the best of all worlds to truly bring the simulation-based experience to life. For instance, A simulated participant may provide very high conceptual and psychological fidelity in that they are a live person who can interact with the learner as a human might and who can evoke a level of cognitive processing similar to that experienced in an actual patient encounter. However, they may have lower conceptual fidelity in the sense that they may not reproduce very specific pathology or may not allow for the performance of certain assessments or interventions. Hybrid simulation allows for the judgment of the simulationist to determine what elements of fidelity are crucial to creating an appropriately engaging scenario for the specific learner population. Simulation teaching tip 11.2 Combining simulators and manipulating the environment, when done well, have the potential to add realism to a scenario and deflect artificiality. One goal of simulation training, regardless of the simulators used, is to achieve the highest level of fidelity necessary for the learners to achieve their objectives, engage meaningfully with the scenario, suspend their disbelief, and have the best chance of transferring their learning in the simulation experience to actual patient care. Different types of fidelity must be considered to achieve the best results with the most responsible use of resources available. This can only be achieved with the expertise of a simulationist who has the ability to construct a realistic work setting from simulation devices, humans, hybrids, environmental cues, and the judicious use of imagination. Summary: hybrid simulation is limited only by the imagination. It requires the simulationist to be proficient in human and mannequin-based simulations and practices. Combining the best methods of simulation to achieve the learning outcomes is the goal of simulationists. Assessment of learners from within, that is, by utilizing simulated participants, has distinct advantages over assessment done by external or remote simulationists. Hybrid simulation methods provide flexibility and realism to help learners achieve the learning outcomes. Chapter 12, Part Task Trainers. Introduction. Part Task Trainers, PTTs, are probably among the oldest types of healthcare simulations known to professions besides practicing skills on one another. PTTs have been used successfully for years to teach healthcare skills and are still a valuable part of simulation education. Simulation education using PTTs allows learners to obtain and/or enhance clinical skills and processes in a safe learning environment. PTTs can be incorporated into all levels of education, from novice to expert. The protected environment and the sense of security enhance students' self-esteem and confidence, thus promoting learning. In this way, the gap between theory and practice is substantially reduced. Practicing skills deliberately helps learners know how to respond when a complex emergency occurs. The comprehensive use and worth of PTT cannot be understated. Spooner et al. State, task trainers are fundamental in the teaching of anatomic landmarks and in enabling learners to acquire, develop, and maintain the necessary motor skills required to perform specific tasks. p. 59. Their vital impact on quality patient care and safety is likely to become more prominent as learners are able to demonstrate enhanced psychomotor and cognitive thinking skills to reach a competency designated as an entrustable professional activity, EPA, for their profession. Choosing to use a PTT allows the faculty to validate a skill prior to practicing a competency on a real patient. PTTs are affordable, easy to move, skill-specific, and allow for standardization of a process. Simulators, fidelity, part task trainers, and complex task trainers. The Healthcare Simulation Dictionary defines simulation as an educational technique that replaces or amplifies real experiences with guided experiences that evoke or replicate substantial aspects of the real world in a fully interactive manner. The dictionary goes on to define the term simulator as a device that duplicates the essential features of a task situation. A simulator generally has three elements: a modeled process which represents, emulates, or otherwise simulates a real-world system, a control system, and a human-machine interface which is representative of the inputs found in the real-world system. Examples include mannequins and PTTs. Fidelity means that a simulator is able to realistically imitate true physiologic realism. Fidelity can be defined as the degree to which the appearance and capabilities of the simulator resemble the appearance and function of the simulated system. Low fidelity is the farthest from realism, showing no physiologic change, movement, animation, or progression. High fidelity is the closest to realism, showing physiologic change, movement, animation, and progression. The anatomic fidelity of PTTs assists students in mastering skills. PTTs are devices designed to train in just the key elements of the procedure or the skill being learned, such as lumbar puncture, chest tube insertion, central line insertion, or part of a total system, for example, an EKG simulator. Examples of PTTs are provided in Exhibit 12.1. Exhibit 12.1 Examples of part task trainers. Intubation mannequins. Forearms. Female pelvises CPR mannequins. PTTs are used in healthcare education and include the anatomic segment relevant to a particular procedural skill. The cost, size, and risk of simulation equipment are considered when selecting resources. They are used to teach novices the basics of psychomotor skills and allow for maintenance and fine-tuning of expert skills. PTTs can be used in situ in a real clinical environment or set up in a simulated learning environment. The benefit of portability adds value to just-in-time education that takes place in relation to a decrease in census and downtime. PTTs minimize the wear and tear of high-fidelity mannequins and are more cost-effective when used to acquire skills leading to an EPA. PTTs range in complexity, from using a piece of fruit to teach injections to using a torso to teach central line placement and care. They typically do not include patient feedback. An important trend is the combination of PTTs with either standardized simulated patients, live actors, or full mannequin simulators to allow for task completion in a more fully immersive environment. It is often difficult to suspend disbelief with PTTs, but they are often used in hybrid formats to increase realism if that is essential to the learning outcomes. An example is placing a task trainer arm for an 4 line in the shirt sleeve of a standardized patient while the actual arm is concealed under a hospital gown. This can prevent pain while the learner is practicing in 4 procedure on the task trainer. Chapter 11 explains the hybrid concept more completely. Complex PTTs increase the fidelity in the learning experience by allowing the learner to use a PTT along with a computer-simulated environment or different evaluative or technological techniques. Examples are provided in Exhibit 12.2. Exhibit 12.2. Examples of complex part task trainers. Surgical skills central line catheterization. Scopes, such as bronchoscopes chest tube insertion. Ultrasound techniques lumbar puncture trainers complex task trainers represent both virtual reality and haptic technology in healthcare education using computer-based technology. This equipment tends to be more expensive. Complex task trainers work better in a simulated learning environment related to portability. Haptic refers to the sense of touch and the meaning of touch. Favier et al. Go on to describe the following levels of haptic fidelity. Simulators with a low haptic accuracy level could be used to learn basic manipulations of surgical materials or instruments and to increase hand-eye coordination. Simulators with a medium haptic accuracy level could be used to become familiar with surgical procedures, for example, learning procedure steps. Finally, high haptic accuracy simulators may help in the acquisition of fine technical skills, such as with tumor dissection. This type of trainer allows the faculty to clearly see where the learner is applying touch and the amount of pressure applied, as well as to assess whether a thorough exam has been done. Complex PTTs are used in combination with web-enhanced simulation programs so that physical interaction can occur within the virtual reality environment. This may be referred to as box-type simulation trainers. They can be used for surgical techniques, such as laparoscopic surgery. Simulation teaching tip 12.1 Learners can often practice on part task and complex task trainers independently if the protocol for the procedure has been taught and is written out. This assists learners in providing self-directed deliberate practice and in being accountable for learning before it is time for evaluation of knowledge. An example used commonly is an 4PTT that is attached to a computer program. The learner must demonstrate knowledge of the correct procedure on the computer for the PTT to respond to the tourniquet and the arm vein to protrude to accommodate an 4 insertion. This may also provide haptic simulation. Curriculum development using part task trainers. Educational goals and simulation tools go hand in hand when thinking about the type of simulator equipment to use. The educator needs to have the end in mind. What will the learner achieve at the end of this learning encounter? The educator needs to identify whether there is financial value in using a high-fidelity mannequin for placement of an 4 line or practice of chest tube insertion when the consumable costs are much higher with higher fidelity simulation equipment. The faculty should weigh the benefits of using a PTT for individual educational encounters against the benefits of using a high-fidelity simulator to place a second line during a critical event in immersive team simulation training. Using technology to provide hands-on experience guided by proven educational principles, we can provide the very best evidence-based learning environment for our future caregivers. Simulation teaching tip 12.2 Part task trainers, PTTs, are easy to transport to a classroom for in situ demonstrations. PTTs are an invaluable asset when setting up a simulation experience for a group of learners. PTTs can be used as an unmanned station for learners to practice as long as they are properly prepared. Chapter 16, Planning Simulation Activities, discusses setting up stations for learner practice in depth. Additional studies are needed that focus on the evaluation of a learned skill on a PTT and the performance of that competency in actual practice, as well as the effect on communication and empathy. Evidence-Based Simulation Practice 12.1. Foronda et al. Quantitatively studied the diversity in simulation centers internationally and found a lack of racial diversity in mannequins, body parts/task trainers, standardized patients, and simulation facilitators. This study emphasizes the need for diversity and inclusion in simulation learning. Advantages of part task trainers. Of all the simulation methods, PTTs are probably the least expensive. Once the equipment is bought, it can usually be used over and over with very little maintenance. Simulation Teaching Tip 12.3 Care of part task trainers, PTTs, is important. Follow the manufacturer's instructions on cleaning and storing PTTs to increase their usability and shelf life. Table 12.1 provides examples of PTTs developed as cost-effective teaching tools to assist healthcare learners in reaching their learning goals. Table 12.1 Examples of PTT use. Authors. Use of PTTs. Kamasawa et al. Used problem-based learning and task trainer for central venous catheter. 2017. Insertion training successfully with medical students. Developed a PTT to teach medical students safe aspiration of peritonsillar. Ng et al. 2018. Abscesses, a common condition that presents in eds. Dedman et al. Used a PTT to improve the fine motor control of surgical residents for 2017. Endoscopic ear surgery. Summary. PTTs are among the first to be used as simulation modalities and are still very effective for student learners when used alone and in a hybrid format. PTTs are cost-effective and can be used by learners independently as well as with the guidance of a simulation educator. When working in simulation, it is important to understand the use of PTTs in teaching the learner a specific skill. Where high-fidelity simulators are invaluable in practicing an entire patient encounter, task trainers allow for the refining of psychomotor skills in isolation. Task trainers allow learners to familiarize themselves with various procedures that require repetitive practice in a safe environment before they are expected to perform the procedure on a real patient. PTTs assist learners in reaching milestones or benchmarks leading to an EPA or competency. Chapter 13, Virtual Reality. Introduction. Today's healthcare environment is fast-paced and, with advancements in technology, is moving rapidly in the provision of patient care and learning environments. There is a large demand for clinical sites within the nursing field alone, and acute care facilities are not able to accommodate the large numbers of students seeking clinical placements. Simulation is increasingly becoming a cornerstone of clinical training, and although effective, it is resource-intensive. In addition, the complexity of healthcare in today's world is moving toward interprofessional collaboration among healthcare providers, increased teamwork, enhanced critical thinking skills and clinical judgment, and time for skill practice. There has also been a proliferation of distance education programs that traditionally have been delivered in a two-dimensional, 2D, environment with limited interaction between the learners and the faculty member. Another pressing need in today's classroom is the ability to host remote learning activities while providing students an effective way to practice their clinical skills. Due to the COVID-19 pandemic lockdowns, healthcare educators needed an alternative approach to teaching in physical classrooms and specialized simulation labs that can be delivered remotely. Changes are needed in the way learners are educated to meet the demands of complex healthcare settings. Virtual learning, VL, technologies are evolving to meet the demands of this changing environment, thereby changing the way healthcare education is delivered. VL encompasses a wide range of technologies. Virtual reality, VR, in healthcare simulation is where a user enters a computer-generated, CG, three-dimensional, 3D, simulated virtual world, VW, that simulates reality and allows learners to interact, practice skills, learn teamwork and collaboration, and manipulate medical equipment. The previous edition of this book explored screen-based VL such as Second Life and Lerdahl's vSim and Voki avatars, which are non-immersive, single and multiplayer online environments where the user experiences the world as an avatar on a 2D screen. Simulation-based education is meant to replicate aspects of the real world in an interactive manner that allows learners to be immersed in the learning environment. Immersive virtual reality, IVR, using head-mounted displays, HMD or headsets, is an emergent technology that is poised to bridge this divide. This chapter begins with a description of VL environments, with a special focus on IVR and its applications in medical virtual reality simulations, VRSs. This chapter also provides understanding of the various components of IVR, the strengths, weaknesses, and current barriers to its adoption in healthcare simulation, and a quick primer to building effective IVR simulations, along with examples of IVR use in healthcare simulation. Immersive virtual learning environments. Immersive VL environments, unlike screen-based VWs, completely envelope the user within an artificial environment, allowing them to fully engage with the surrounding in all directions. A well-designed IVR presents the virtual learner with a realistic simulation of a healthcare environment that replaces their real world, convincingly enough that they can suspend disbelief. This has been achieved through technologies like VR headsets or multiple projection systems like the Cave Automatic Virtual Environment, CAVE. While VR replaces the user's real world, augmented reality, AR, superimposes digital information over the existing physical world. There are a variety of healthcare education tools that use semi-immersive or using mobile devices, as well as fully immersive AR, sometimes referred to as mixed reality, where virtual objects coexist along with the physical world, like the Microsoft's HoloLens. XR or extended reality has become an umbrella term encompassing augmented, mixed, and virtual realities. The term metaverse gained notoriety when Facebook, now Meta, used it to describe 3D spaces that allow users to socialize, learn, collaborate, and play. Although several other elements are attached to the metaverse, like the blockchain, non-fungible tokens, NFTs, and Web3, for the scope of this chapter, we will adopt Meta's definition. Most XR offerings are single-use and single-user applications. Multi-user virtual environments, MUVE, like AltSpace VR, VR Chat, Engage, Verbala, and Horizons allow users to interact with others using avatars, while providing a familiar portal to enter the metaverse. Many of these IVR experiences are packaged in the form of single-use applications. Simulation learning systems, SLSs, on the other hand, combine the IVR experience with a learning management system, LMS, enabling learner login, progress tracking, assessments, and an interface to interact with the instructor and peers. IVR has been used since the 1960s for activities such as gaming, therapeutics, training, and more recently teleconferencing. Its efficacy as a vital teaching tool has already been demonstrated in multiple fields, including aviation, oil, shipping, and the military, where real-world training is either prohibitively expensive or extremely dangerous or both. Healthcare training also addresses dangerous life-threatening scenarios where learners gain a certain level of competency in simulated environments before they are allowed to work on real patients. However, it was not until the release of reliable, low-cost portable consumer HMDs, like the Oculus Quest, that healthcare educators' institutions have found it financially feasible to incorporate IVR into their curriculum. The key features of the IVR environment include the following. Enhanced immersion and presence replicates authentic real-world spaces and activities, allows users to interact with the virtual environment through embodied avatars, allows users to communicate and collaborate with other users in the same environment. Haptics, rich multisensory feedback, and biosignal integration. The use of IVR as an educational tool is grounded in the theory of situated cognition. The sense of self-location, the sense of agency, and the sense of body ownership are critical to learning. Although IVR gives students a safe, realistic environment to help healthcare programs provide simulation virtually, determining if IVR is the right technology for the learning objectives takes careful consideration. In the next section, we will explore the various elements that make up an IVR simulation. Teaching tip 13.1 Presence improves memory and coding. For meaningful learning to occur within immersive virtual reality, IVR, learners must apply their knowledge to practice and learn from mistakes in realistic environments. Virtual reality headset. A VR headset uses digital screens placed in front of the eyes to completely replace the visual field with an artificial environment. Some have adjustments to match the facial characteristics of the wearer to effectively render binocular vision. Before designing VRS modules, it is important that every educator experiences IVR firsthand on a VR headset. The choice of the headset vastly changes the fidelity of the simulation as well as its accessibility to the learners. There are two broad categories of VR headsets. PC-based VR headsets like the Oculus Rift, HTC Vive, Valve Index, Varjo XR3, and Microsoft HoloLens offer a high-fidelity VR experience with high-quality graphics and precision motion tracking. However, these setups are expensive and require dedicated high-performance gaming computer and a pre-calibrated room space. Portable VR headsets like Meta Quest, Pico, Varjo Aero, and Samsung Gear VR, smartphone-based VR, can be set up anywhere. These are battery-powered, lightweight, standalone units with cloud connectivity and moderate amount of internal processing power for offline use. VR can deliver the clinical scenario in a small space, 2 times 2 meters, with under 5 minutes of setup. VR headsets have built-in head tracking and are usually paired with handheld controllers, which are the primary user input devices in VR. Newer headsets come with fully articulated hand and eye tracking, eliminating the need for controllers. Environment. Creating a realistic learning environment is an important part of immersion. VR can transport the user to any VW, including abstract ones, like in the dreams of DALL-E. In healthcare simulations, fidelity in representing the environment increases learner engagement, an essential component of learning. CGVRS, like the ones offered by SimXVR, UbiSim, Oxford Medical, Simulation, and Health Scholars, incorporate interactive 3D objects, like flashlights and medical instruments, and virtual patients, VPs. CGVRS can also be used in Move by incorporating distance learning and telepresence. Educators have also developed custom CGVRS using software platforms like Unreal and Unity. Ultra-realism in these environments is still only possible on very sophisticated and expensive VR systems, making these inaccessible to many learners. On the other hand, Embodied Labs makes use of 360 degrees or immersive videos in their VL program. Live capture of real environments and real people using 360 degrees cameras gives much more visual fidelity and leads to a more realistic decision-making. This allows for more accurate representations of facial expressions, movement, speech, and subtle body language cues, which are essential for good soft skills training. For healthcare educators with expertise in staging and filming simulations, it is likely faster to create content using 360 degrees VR than developing a full CG immersive environment. Interactive elements like clickable hotspots, branching logic, and quizzes can be added to 360 degrees VR content using video authoring software like Scenario VR, Uptail, and 3D Vista, thereby keeping the learners engaged. For these reasons and for its low cost of entry, immersive video-based IVR is the most common medium in VR education. It has several benefits over screen-based learning, from increased student acceptance and higher engagement, to fewer distractions. Unlike in-person simulation, with 360 degrees VR, all learners get the best vantage point from which to watch the simulation. This could be the patient's view, the healthcare worker's view, a bystander's view, or a drone view, or learners could switch between views based on the content narrative. One limitation of 360 degrees VR content is that the viewer can only experience the world from the camera's point of view. This restricts freedom of movement by the user, which is sometimes beneficial for new users who tend to wander off in an IVR. Also, to minimize motion sickness, these experiences are best viewed while seated and are ideal for implementation in existing classrooms. Avatars. Avatars are the digital representation of users in a virtual environment and the most common way of embodiment and interaction within the metaverse. Other users and non-player characters that occupy a virtual environment are also commonly referred to as avatars. The faculty and learners enter the VW by creating an avatar. The participant creates the characteristics of the avatar, including eye and hair color, clothing, age, race, ethnicity, and gender. However, it is highly recommended that the learners create an avatar that mimics their own features and appearance. Avatars interact with each other through talk, text, and gestures, as well as move around, perform skills, role-play, and even play in world games. In most current IVR systems, avatars are represented by a head and 2 hands connected to a floating torso, since these systems use head and hand tracking only. Most users have been able to embody such avatars and use them as extensions of their real self, although realistic full-body avatars were rated significantly more human-like and evoked a stronger acceptance in terms of virtual body ownership. Simulation Teaching Tip 13.2 Personalized avatars significantly increase virtual body ownership, virtual presence, and dominance compared with generic counterparts. Hence, Avatars representing the individuals embodying them should be as realistic as possible. Virtual patients. A VP is an interactive computer or video-based simulation of a real-life patient within a clinical scenario. Learners will either observe the VP or assume the role of the healthcare professional in the scene. Some computer-based VRSs allow the learner to create an avatar that will represent them within the scene. The role of the learner can be any healthcare professional, depending on the design of the VRS. Within their role, the learner can make judgments and clinical decisions based on the assessment of the VP. Participants learn the role of the professionals they represent through their assessment, clinical diagnosis, treatment, and care of the patient, just as they would if interacting with a real-life patient. The VP should have the same medical presentation for the learner as a real person with the same diagnosis. Depending on the program used to view the VP in VR, the learner may be able to speak with or interact with the VP, and in certain advanced simulations the VP can employ artificial intelligence, AI, to process and respond to the learner based on its character setting. VP simulations are case-based computer simulations in which the user observes or makes choices as they progress through various steps. The pathway for clinical decision-making may be pre-programmed or may have a branching algorithm, which allows for several alternative pathways depending on each action taken by the learner. Serious games. Gamification is the application of typical elements of game playing, for example, point scoring, leaderboards, team activities, meaningful stories, in non-game environments. The term serious games has loosely been defined in several contexts, including technology for professional use, interactive video simulation, avatars, and watching videos. The serious game has as its primary purpose educational and professional goals and not entertainment. Serious games are computer-based simulations and combine knowledge and skills development with video game playing aspects, thereby enabling active, experiential, situated, and problem-based learning. Serious games have been used to enhance the clinical reasoning, decision-making skills, and collaborative work of nursing students in a realistic, safe environment. Students enter the VW on a computer and can interact in a realistic environment to practice skills and develop different competencies. One of the major limitations of screen-based learning is that interactions are limited to the mouse and keyboard on a 2D interface. Interactions in VR could still use point-and-click mechanics, but also add a layer of spatial as well as gesture-based interactions to mimic interactions in the real world. This added level of motor planning and interacting with VR elements is key to making an engaging learning environment. Fully articulated hand tracking, eye tracking, electromyography, EMG, and other biosignals have been used in VRS to increase fidelity and learner engagement. Haptics is another essential component that uses robotics and other physical means to allow users to experience realistic interactions. Although studies have found that IVR is not yet a viable replacement for in-person training, it does show benefits in reducing anxiety among vocational and early learners and engaging remote learners. The learner-centered approach is when the player controls the learning through interactivity. The game can be designed so that as the student makes a choice with regard to an action or intervention, it leads to another step based on the previous decision. This design fits nicely with Kolb's experiential learning theory. Serious games may be designed as a means of summative evaluation based on specific outcomes or provide a means for formative evaluation to determine whether learning is occurring. Simulation teaching tip 13.3. The simulation or scenario must be appropriate for the level of the learner to minimize frustration and maximize engagement. Soft skills. IVR simulations have been used in a variety of learning scenarios, including training clinical and procedural skills, cognitive decision-making and situational awareness, staff orientation, and lab safety orientation. However, the major transformative power of IVR is in the psychological effect it has on the user in the way of altering consciousness. VR is even touted as the ultimate empathy machine, an essential behavioral competency required of healthcare providers. This is often expressed when the learner experiences IVR through the point of view, often referred to as first-person point of view, of another individual, a form of to walk a mile in someone else's shoes. Some examples of these experiences include aging-related symptoms, blindness, hearing impairment, and racial bias. Although clinical skills are the most critical element of their practice, communication breakdowns are the most common cause of medical errors. Communication, collaboration, and delegation are frequently thought to be soft skills. IVR can not only improve communication and delegation in critical situations like the Advanced Cardiac Life Support, ACLS, training, but has also been used to improve communications with patients by having the caregiver experience patient-specific symptoms themselves as well as through interactive communications with a VP. With the rise of multidisciplinary and sometimes international team-based approach to healthcare, IVR can facilitate quality interprofessional education at scale and without geographic limitations not only among healthcare learners but also related tracks like biomedical engineers, for whom clinical simulation training is cost prohibitive or unavailable. Theoretical frameworks. Serious games should be designed based on the objectives of the game, outcomes to be met by students, and processes that have a theoretical basis. The three main theoretical approaches are the constructivist theory, Kolb's experiential learning theory, and Knowles's adult learning theory. The constructivist learning theory states that learners construct knowledge based on their experiences in relation to an event. The constructivist theory supports the movement of the learner from the novice to the advanced beginner level and recognizes that actions by the learner may be determined by previous exposure to a situation as well as the knowledge base of the learner. Epp et al. Describe the constructivist theory as a collaborative practice that assists the learner in developing their knowledge, skills, and attitudes by adding new knowledge to previous learning to build deep understanding of a concept. Scaffolding, associated with the constructivist theory, has faculty facilitating learners as they move through simple to complex concepts as they reach new potentials and independence. When designing a serious game using the constructivist theory, it is important to formulate objectives and outcomes prior to the development of the scenario for the game. The level of the learner must also be taken into consideration. For example, a scenario designed for a beginning nursing student may require the instructor to be more actively involved in the game based on the learner's limited knowledge. As the student moves through the curriculum, there is less involvement from the instructor, and eventually the student assumes total control of the decision-making in the scenario. This type of design is termed instructional scaffolding. Kolb's experiential learning theory provides a solid platform for the design of VL activities. Kolb describes learning as the process whereby knowledge is created through transformation of experience. p. 41. Kolb suggests that a person learns through concrete experience, which provides a basis for observation and reflection on the experience in the virtual simulated environment, and discovers new knowledge. Kolb further proposes that reflections are then assimilated into abstract concepts and can be applied to a new experience. This in turn suggests that learning which has occurred from a simulation in a virtual environment can be applied to situations encountered in the real world. Green et al. Postulate that Vygotsky's activity theory is important in the relationship of engagement in VWs. Vygotsky espoused that learning is a social experience and learners should be actively involved in their learning. Vygotsky proposed that social interactions are fundamental to the process of cognitive development, and that connections between people and how learners interact in shared experiences are essential to collaborative learning. The VW is ideal for social interaction with simulated environments. Simulation teaching tip 13.4. The development of a serious game should be based on sound theoretical principles and designed around the purpose, objectives, and outcomes of the learning exercise. Knowles's adult learning theory can also be applied to the VR environment and development of serious games. Knowles proposed that adults learn differently from children, and their learning is dependent on autonomy, life experiences, personal goals, and relevance of the experience. He termed this andragogy. This theory is applicable to the VR environment as the learners can apply theoretical principles to the situation and receive immediate feedback on their decisions and actions. Virtual environments can stimulate adult learners to apply their knowledge and experiences to concrete situations in a controlled environment, then consider the consequences of their actions and make changes to future choices. Learners are actively engaged in the learning process through simulated activities and can apply what is learned to real-life situations. Advantages and disadvantages of immersive virtual reality simulations. The integration of VR learning is important in the learning environment in order to allow the learners an opportunity to immerse themselves in environments where they can practice skills, interact and collaborate with peers or other professionals, make decisions related to care and interventions, and manipulate equipment without fear of harming an individual. VL simulations can be used in any area of clinical practice, but are especially useful in environments where there is limited access to the experience, such as disaster or perioperative nursing. Some benefits and limitations are described in Table 13.1. Table 13.1. Advantages and disadvantages of an immersive virtual reality simulation. Advantages/benefits, disadvantages/challenges. It allows learners to repeatedly practice complex. The initial cost of setting up a VR facility with and demanding tasks in a safe environment and necessary hardware and software is high. Improves learning retention. It provides a rich, interactive, and engaging. It lacks existing educational content. Creating advantages/benefits, disadvantages/challenges. Educational context that supports full immersion. Custom VRS is expensive and time-consuming. And better training effectiveness. Body-tracked avatars allow for self-expression. Educators and learners must be oriented on and realistic interaction, thereby increasing how to use VRS to minimize learner confusion. Embodiment and engagement. It offers a student-centered approach by reducing technological support. Must be available to real-world distractions and promotes active users and designers. Learning. Spatial telepresence and move foster cybersickness and technical challenges. Break collaboration with peers and users from other immersion and cause learner frustration. Disciplines, both locally and globally. Serious games are much more effective in educators and learners must keep an open immersive environments that use gestures to mind and be willing to experiment with VRS. Interact. Increasing immersion and presence. There is a lack of empirical evidence on the necessary for the suspension of disbelief, leading impact of VL over traditional teaching to better training effectiveness. Methods. Unlike standardized patience, virtual characters, it is very effective in improving soft skills such are not yet suitable for certain learning as communication, collaboration, and delegation. Objectives. Cost per learner for VR training gets cheaper. Lack of interoperability between headsets and over time when compared with mannequins or live software limits VL offered to learners. Advantages/benefits, disadvantages/challenges. Exercise training. It lowers learner anxiety and in some instances changes in VR market are swayed by other cognitive load, while improving creativity, industries like gaming, therapeutics, and positive effect, and confidence. Industry training. Health and safety risks associated with virtual reality. VR is an innovative technology that is becoming more ubiquitous in the realm of healthcare simulation. This technology has great potential in informing learners in the health sciences. However, there are also potential risks to learners' health and safety. These risks can be mitigated by careful planning, management, and monitoring of learners' VR experience. Cybersickness is one potential issue in certain users of VR. Cybersickness occurs when there is a divergence between what is seen and the vestibular system in the inner ear and brain controlling balance and eye movement. Cybersickness is similar to motion sickness and can cause the wearer of an HMD nausea, dizziness, and general disorientation. This can be mitigated by teaching the learner to move their head slowly, briefly close their eyes, or lift the headset away from their face until the sensation passes. However, even with these interventions, some people who are very sensitive to the sensations caused by the VR display may not be able to participate. If this occurs, a 2D version of the simulation should be available. Another risk is immersion injury. When donning the immersive HMD, participants experience sensory deprivation of the real world around them. Although immersion, the hallmark of the VR, transports the participant into the VW, it also exposes the wearer to potential injury from collision with persons or objects, or the potential for falls when wearing the HMD. This factor can be eliminated by having the wearer remain seated during the scenario. It is also helpful to have the learner seated in a chair that can rotate 360 degrees. A chair that can rotate allows the viewer to observe all of the actions within the scene. If the VRS does not permit the wearer to remain seated during the simulation, adequate room without obstacles that can cause potential injury or contribute to a fall should be the setting where the experience takes place. Another potential for harm is the transmission of disease from the HMD and controllers. This has become a prevalent issue in education since the outbreak of COVID-19. Meticulous cleaning and sanitizing of the HMD and controllers must be employed between use of the VR equipment. Consider the construction of the equipment when determining the best method for cleaning and sanitizing. Electronic components should not be exposed to moisture. Lenses within the HMD may become scratched or clouded by harsh chemicals. Lens cleaning wipes designed specifically for optics will protect the lenses. Using UV light is one consideration for sanitizing the HMD and controllers. Sanitizing wipes should also be utilized in order to kill the bacteria and viruses on parts of the HMD and controllers that are in contact with the skin. Designing an immersive virtual reality simulation. There are several steps involved in designing and implementing an effective VRS learning module. As with any course, the first step is to identify the content of the lesson and map out the learning objectives. Based on the strengths and weaknesses discussed earlier, and keeping in mind current institutional readiness, funding, infrastructure support, and class size, educators can decide if IVR is the right medium. Here are some considerations for IVRS educators. Cost and availability. VR headsets are expensive, ranging from a few hundred to a few thousand US. From an institution's perspective, there are other infrastructure needs that add to this cost, such as mobile charging stations, UV cleanbox, desktops, and VR-compatible rooms. Although in the case of healthcare simulation, where the cost of live training is much higher, the larger initial investment in VR can be spread across a large number of trainees and longer period of time. There is also hesitancy among institutions in investing in these technologies due to changes in market offerings. An example would be the unexpected demise of the Oculus Go production when several institutions have invested on these headsets. However, these have been replaced by a more capable Oculus Quest. Also, the ideal would be one headset per student. However, for big class sizes, institutions have managed with one headset for every 10 students. Content and integration. The lack of relevant content has been the main reason cited by educators who want to adopt IVR as a learning tool. Educators who have been developing custom teaching videos and learning materials for their simulation laboratory and screen-based courses will find 360 degrees VR an effective way to create immersive content. CGVRS typically require working with a software development team and would take a few months to create. It would be worthwhile to check the marketplace for pre-existing VRS content that is both effective and relevant to the learning objectives. Interoperability and tech support. As the marketplace for IVR expands, new and proprietary hardware and software products emerge. When educators purchase a specific device for their IVR curriculum, the gear they ultimately choose sets up a trajectory of subsequent decisions dependent on the implications of that headset selection. The XR community recognizes the importance of interoperability, and several standards have been projected as viable pathways for hosting XR content, agnostic to the delivery device. WebXR is a new standard for XR running through web browsers. It supports both VR and AR content and can be viewed on any web browser, including computers, smartphones, tablets, and VR headsets. The fact that WebXR-based content can be written to work out of the box in simple consumer devices makes this technology widely available and accessible, as virtually any user with an internet connection and a capable device can benefit from it. Similar steps are being taken to standardize SLS and education applications developed to run on VR headsets, including concurrent non-immersive offerings and LMS integration. Institutional support for training educators on developing XR modules is also an important consideration. Guides developed by instructional support, information technology, IT, and peers help set the stage for newcomers to quickly bring their vision to the classroom. Like any modern electronics device, VR devices, even the plug-and-play ones, require periodic maintenance, like software updates and recharging the batteries. If overlooked, it can pose major delays, especially in synchronous sessions. Think Reality by Lenovo is a device management platform that can remotely monitor the charge level and update the status of their VR headsets. University initiatives in establishing immersive learning centers like the XR initiative at the University of Michigan or the VR pilot projects at Georgian College have shown high degree of success in student engagement, remote learning, improved outcomes, as well as serving as a training hub for the rest of the XR community. Several leading universities are now offering online courses on XR module development for education. Once the VR content is ready for the learners, the next step is setting the VR classroom. There are several ways of conducting a VR course: synchronous or asynchronous, in-person or remote, self-guided or instructor-led, and individual or in groups. A VR session can be broken down into the following phases: orientation, briefing, action, and debriefing. Orientation. Most learners and educators are new to IVR and must be properly oriented to the technology prior to actual VL. Learner confusion can be induced through various factors, including complex instructions, insufficient orientation, and ill-developed learning modules. Because IVR can be extremely immersive, complicated button presses, motion sickness, disorientation, and technical issues increase frustration and break immersion. Educators should aim to design their course to find the right balance between engagement and frustration. However, even with all these provisions, some learners may not be able to benefit from IVR either due to physiologic incompatibilities with technology or by choice. Such learners should be provided with viable alternative learning tools. Briefing. During the briefing stage, learners create their avatar and familiarize themselves with the platform interface. Unlike screen-based learning, IVR learners cannot interact with the real world once they are immersed in the VRS. Educators should incorporate adequate instructions in the briefing or incorporate them within the VL so that learners should not have to break immersion within the VRS. Educators must be cognizant of the learner's physical safety in VRS that require them to look and move around. This may be a quick check to clear the physical surroundings to avoid serious injury or falls. Action phase. Learners enter the VW scenario created for them. Instructors and teaching assistants must be cognizant of the learner's inability to see their real world. Some VRS have companion apps through which the educator can monitor in real time their learners' progress and engage with them live in the VRS. Learners interact in the environment based on the design of the simulation, which may be acting alone or working in teams and collaborating with others. Some learners may feel a sense of shock due to the sudden change in environment when they remove the headset. Debriefing in healthcare simulation. Debriefing is where most of the learning occurs. It is a key feature in designing VWs and should be done after each VL experience. Educators facilitate the reflective observation, of learners' experiences during the simulation. Meaning, abstract conceptualization, is derived from the experience. Further application of the meaning may be initiated. Debriefing after VRS can be done either in the traditional classroom, within and move, or even with AI avatars. Educators should also consider including VR-specific questionnaires for items like presence, simulator sickness, and user experience to better understand their learners' needs. Community resources. The VR education community is small but very active and is a great resource for VL educators and learners. Several professional organizations such as the Immersive Learning Research Network, ILRN, VR/or Association, VURA, International Society for Virtual Rehabilitation, and Institute of Electrical and Electronics Engineers, IEEE, VR have incorporated VL as a key vertical in their organization. Since IVR is an area heavily influenced by industries like gaming, therapeutics, industrial training, and many others, these membership organizations play a pivotal role in bringing together educators, hardware manufacturers, software developers, and solution integrators to share ideas and solutions to further the implementation of VR in education. Attending online workshops and conferences is a great way to interface and collaborate. Several publishers, including Frontiers, Springer, and Elsevier, have dedicated journals and special topics on VL. In keeping up with times, social media and podcasts provide up-to-date information from educators, content creators, and researchers, as well as industry experts and market trend analysts. Podcasts focusing on VL include Voices of VR, VR in Education, and Everything VR and R, Evidence-Based Simulation Practice 13.1. Educators shared their experience of embedding virtual gaming into a nursing school curriculum. Purpose: share the lessons learned from the development and incorporation of virtual gaming into a nursing course of study. Design: how to decide the best virtual gaming simulation, VGS, that aligns with the course content and meets the course learning objectives, and the importance of having a pre-brief before the virtual game, enactment, debriefing, and evaluation of the virtual simulation game. Methods: educators are continuously challenged to actively engage learners. The researchers in this study created virtual gaming simulations to augment their learners' education. The VGS presented learners with a realistic scene of a nurse-client encounter. After viewing the film clip, the learners were presented with options on how to proceed. If they chose incorrectly, they were directed to choose another answer and continue with the simulation. Learners were given a summary of their achievement during the simulation and the opportunity to repeat the VGS as often as they would like. Results: the researchers believe having both the educators and the learners involved in the development of VGS will improve the acceptance and applicability of this type of simulation. They also stress the importance of a pre-brief before and a debrief after the simulation. Evaluation of the experience is essential to learn from the experience and to make improvement on future VGS offerings. Conclusions: there is an exponential increase in the use of VGS in education. Learning from and sharing best practice in virtual gaming will help establish best practice guidelines in this emerging field of active education. Evidence-Based Simulation Practice 13.2. A pilot study was designed to teach airway insertion skills to nursing faculty and students using immersive virtual reality, IVR. Purpose: Teach students difficult airway management skills using virtual reality, VR. Intervention. Design. Survey sampling was combined with a quasi-experimental, one-group, pre-test, post-test designed to assess the fidelity, realism, potential adverse effects, and efficacy of a VR intervention for airway management among undergraduate nursing faculty and students. Methods. The Airway Management VR Laboratory is a computer-generated IVR, CGI VR, delivered over a PC VR setup, Oculus Rift, with dynamic haptic feedback delivered through the handheld controllers. This voiceover narration-guided intervention consists of 6 lessons orienting learners to basic skills and processes associated with airway management for an unresponsive and apneic patient. Detailed step-by-step instructions and dynamic positive reinforcement haptic feedback were added to keep the users engaged. Gamification in the form of level unlocks was also added as a reward mechanism. The total instruction time was 20 minutes. Web-based survey instruments included a presence questionnaire which assessed the realism of the experience, a VR sickness questionnaire which assessed cybersickness, and a validated knowledge test. Results: 10 faculty members and 21 students participated in this study. The faculty and students rated the VR Airway Laboratory as having high presence, no cybersickness, and significantly improving knowledge of airway management, p less than 0.0001. The faculty and students, overall, felt the airway management intervention oriented them very well. Conclusions. The authors argue that immersion brings about psychological fidelity within VR, which actively promotes learner engagement. Immersive spatial representations coupled with vestibular and proprioceptive senses can have a positive effect on memory recall. The VR Airway Laboratory is an efficacious means of teaching difficult airway management skills to nursing. Summary: this chapter discussed VL modalities, including IVR, VPs, VRS, MOVE, and serious games, and has looked at the design of these modalities and their effectiveness in the learning environment. There are concrete advantages to using VL environments, which include promoting interprofessional collaboration and providing experiences that mimic real-life situations and are easily transferred to the clinical practice setting. Disadvantages of VL include the cost and extensive faculty development required to design the scenario. There are also health and safety issues associated with the use of VR. The learner must also be oriented to the VL platform in order to be successful in maneuvering within the scenario to enhance their learning experience. VL and VRS can be used in the education of healthcare professionals when there is an increased demand for clinical placement and, at the same time, fewer resources of time and space available for learning. The uses of VL and their outcomes are expanding in academia and show much promise in enhancing the learning environment and improving learning outcomes.